Welcome to the 8th and final meeting of the Joint Interim Standing Committee on Health and Human Services. We will call the roll first. For those members attending virtually, please turn on your cameras and respond when you hear your name. Madam Secretary, please call the roll.
Senator Danyate. Senator Hardy.
Here.
Here.
Senator Harris.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen. Assemblyman Orenlicker.
Here.
Assemblywoman Titus.
Here.
Chair Peters.
Here. Thank you so much. Will you please mark Assemblyman Hafen absent excused from today's meeting? I am down here in Las Vegas to kick off this last meeting with my colleagues down here. I wish we could all be together, but knowing certain circumstances, we are still entertaining this three-modal model. Just a couple of housekeeping items, as we've done every committee meeting, so everyone's on the same page. First, I'd like to remind everyone to please silence all of your electronic devices. I think I have to do my own here too. Yup. For members joining online, please mute your microphones when you are not speaking and leave your cameras on so we can ensure you're there. Additionally, I ask our presenters on the Zoom video call to leave your cameras off and microphones muted until I call up the agenda or work session item under which you will present, or if I direct any questions to you. The Zoom video call has a chat feature. However, this feature is only to be used for technical assistance. Any links or information that you would like to share during your presentation should be stated verbally on the record and follow up with an email to staff. Agenda items may be taken in a different order than listed. 2 or more agenda items may be combined for consideration. Any item may be removed from this agenda, and discussion of any item on the agenda may be delayed at any time. The committee meeting materials can be found on the Nevada Legislature's website. You can also sign up for electronic notifications related to any activities on the committee's website. If you wish to testify in person, please sign in at the table by the door and leave a business card. If you do not testify, you may also want to sign in there so there's a record of who's in attendance and who's interested in a particular topic, and in the event the committee needs to contact you later. When testifying in person, please turn the microphone on to speak and off to listen, because we have others listening to and viewing the meeting in in Carson City and online. We do get some reverb, so this is something I'll remind you about if we have any issue with it. And with that, we're going to go ahead and move into agenda item number 2, public comment. Is there anybody in Las Vegas who would like to public comment? Please come to the table. Public comment will be limited to 3 minutes per speaker. Staff will time each speaker during public comment to ensure everyone has a fair opportunity to speak. We also ask that you do not repeat what a previous commenter has stated. An additional opportunity to make public comment will be available at the end of the meeting. Since we will be having a work session today, I encourage individuals to address any item on the work session during this first public comment period. This does not preclude me from requesting clarification if the committee has questions regarding specific items in the work session document. Therefore, to ensure that you have an opportunity to present your views, you may want to address items in the work session during this first public comment period. In addition to testifying in person, members of the public may provide public testimony in 4 different ways, all of which are listed on the agenda. We will start with public comment for those in the physical locations. I've already asked if there was anyone in Las Vegas for public. Okay, we have someone coming up to the table. And then we'll go to Carson City and then our virtual folks who may be calling in. Please state your name and spell it for the record, and proceed when you're ready.
Thank you, Chair Peters. Bradley Mayer, partner with Argenta Partners, BRADLEYMAYER. I'm here today on behalf of the Southern Nevada Health District, and I wanted to specifically call out item L2 that we're in support of. You know, these kind of categorical dollars are critical to improving Nevada's population health. You know, the threats in public health are changing all the time. And so having the ability to address chronic disease, health disparities, and emerging threats and the like through this proposal is critical. And so we urge your support, and we thank you for considering it. Thank you.
Thank you for your comments. Is there anyone else in Las Vegas who would like to provide public comment? Seeing none, we'll go ahead and go to Carson City. I can see in the reflection that there are a couple people at the table, so please turn on your mic, state your name and spell it for the record, and proceed when you are ready.
Good morning, Madam Chair and members of the committee. For the record, my name is Jay Parmer, and I'm here today on behalf of the Association for Accessible Medicines. The Association for Accessible Medicines is the national trade association for the generic and biosimilar pharmaceutical industry. I'd like to refer you to a fact sheet that was in your meeting materials. It was distributed to you in advance, and I'd like to highlight a few points on the fact sheet for your consideration as you go into your work session today. I want to point out that the generic and biosimilar drugs provide one of the top value propositions in healthcare. And here's some statistics to support this statement. In 2020, healthcare spending in the U.S. reached $4.1 trillion, yet generic drug spending accounts for only 3% of this massive number. Looking specifically at Nevada, in 2020, generic and biosimilar drugs saved the state Medicaid program $485 million and saved the Medicare program $711 million. When combined with commercial and private payers, the overall savings from generic and biosimilar drug utilization to the state of Nevada totaled $2.6 billion. And that is correct, that's $2.6 billion. When talking about prescription drug spending nationally, new data for 2021 shows generic drugs now represent 92% of all prescriptions filled, but account for only 16% of all prescription drug spending. The data shows even more savings compared to 2020, when these numbers were 90% of all prescriptions and 18% of all spending. This means that even as more generic drugs are being dispensed, the share of the overall cost continues to drop. As we all know, patient costs are really the most important issue we're all concerned with today. On average, the patient copay for a generic drug is $6.61, while the average copay for a brand drug is $55.82. According to a recent AARP study, they reported that the cost of the 390 most commonly used generic drugs by seniors has fallen by 9.3%. It's important to note that generic and biosimilar drugs have entirely different economics than brand drugs. Generic drugs are a commodity market, and as a result, profit margins are smaller, and distribution is largely handled through three major wholesalers. Generic manufacturers do not set the price patients pay for a prescription drug. Once a generic drug manufacturer sells to a wholesaler, the manufacturer is effectively removed from the pricing discussion. In summary, as you craft legislation for the next legislative session, please keep these critical facts in mind. By supporting policy that encourages increased generic drug utilization, you can help lower the cost of health care and improve access to care for all Nevadans. Thank you.
Thank you for the comments. Next in person, please turn on your mic, state and spell your name for the record, and proceed.
Good morning, Chair Peters and members of the Healthcare Committee. This is Joanna Jacob. I am Government Affairs Manager for Clark County. I was supposed to be joining you today in Grant Sawyer, but got stuck here in Carson City last night. So very happy to be here in Carson City and testifying today on item D1 in your work session. Is an item that Clark County did submit for consideration, so would like to thank you for including it on today's work session. The intent of this request really is to provide a path forward for child welfare agencies to bill federal 4E dollars for a model of care that is emerging from the Family First Prevention Services Act that is called a Qualified Residential Treatment Program. And some of the guidance that is coming down from the Federal Children's Bureau really showed us that there may need to be some updates to the Nevada revised statutes, and that is to align with that guidance to provide that path. I do want to say a few things with respect to our intent and plans forward, that we are working with the state DCFS, the Department of Welfare and Supportive Services, because there are quite a few moving parts with respect to how we are going to license this part, with Clark County and with Washoe County and any stakeholders whom the state will designate on this bill. We intend to bring you a consensus product, really, to say that to move us forward to provide this path. It's tremendously important for Clark County because the federal guidance states that we will no longer be able to bill for dollars for this group home kind of model of care unless, beyond 14 days, unless we have certain exceptions, one of which is this qualified residential treatment program, which the federal guidance also tells us needs to be licensed by the state as a child care institution. And our definition in Nevada did not match the federal guidance, and that's the intent of the BDR. So I wanted to say that we will work with our child welfare agency colleagues and our state colleagues on this bill, and want to thank you for including it today for action and ask for your support. Thank you.
Thank you so much, and we appreciate your commitment to continuing the work on this issue. Is there anyone else in Carson City who would like to come up for public comment? Seeing none, I'll go ahead and ask BPS if they can check the public comment line for folks calling in for public comment.
Thank you, Chair. If you would like to offer public comment on today's meeting, please press *9 now to take your place in the queue. Once more, that's *9 now to take your place in the meeting to offer public comment.
Good morning, Chair Peters, Vice Chair Jonyate, and members of the committee. My name is Jimmy Lau, first name Jimmy, last name Lau, Lau. And I'm the Vice President of Ferrari Reader Public Affairs, representing Dignity Health St. Rose Dominican. On behalf of St. Rose's nonprofit acute care hospital system in Nevada, we want to thank the committee for its diligent work this interim and offer comments in support of 2 items on the committee's work session document. First, we'd like to offer our support for item L, specifically the creation of a public health infrastructure and improvement account. This item will provide ongoing support for Nevada's public health infrastructure, complementing the work of community stakeholders across our state. St. Rose is proud to be a part of Nevada's public health infrastructure, offering many free and low-cost programs through its foundation and wellness centers to address social determinants of health for Nevada's most vulnerable and disadvantaged residents. Second, we would like to offer our support for item K related to community health workers. St. Rose has supported legislation in previous sessions related to community health workers, recognizing the substantial value they provide to the communities they serve. Expanding access to community health workers will provide an immense benefit to Nevada's residents, and we are hopeful this revision to the existing statutory authorization for community health workers will allow St. Rose to bolster its work in providing high quality and accessible services for Nevadans. We look forward to working with the legislature on these measures in 2023. Thank you for your time and consideration.
Thank you for the public comment. And are there other folks on the public comment line?
Good morning, Chair Peters and members of the committee. My name is Megan Kamlasi, and I am the Associate Director of the Center for Public Health Excellence within the School of Public Health at UNR. First, I want to thank Senator Jonyate for all the time and work he and staff put into the SB 209 study. Through it, he received a significant amount of feedback, the results of which are reflected in the work session today. For many, the COVID-19 pandemic provided the first concrete example of what the public health sector does and underscored the importance of robust public health systems. It also highlighted the consequences of chronic underfunding, workforce shortages, and outdated infrastructure, which limited the state's capacity to respond to public health challenges before the pandemic and exacerbated them during the crisis. The proposal before you in item L in the work session document regarding public health modernization represents a significant step toward improving the ability of public health practitioners to prevent and respond to health crises in the state. It's ongoing flexible funding that will be a perfect complement to the historic investment in public health infrastructure that the Interim Finance Committee approved yesterday. As you consider these proposals today, I think it's just important to remember that there are hardworking public health professionals who are currently stretched thin, who are doing the best that they can with the funding and the staff and the capacity that they have. And this non-categorical funding will just enable them to address whatever the public health issue is of the day and respond to the needs of the residents and the communities you serve. Thank you for your time.
Thank you for the public comment. Are there other folks on the public comment line?
Yes, Chair. One moment. If you would like to offer public comment for today's meeting, please press star 9 now to take your place in the queue over the phone or raise hand inside the Zoom client. Once more, that's star 9 now over the phone or raise hand inside the Zoom client to participate in public comment.
Good morning, Chair Peters and the rest of the committee. This is Dora Martinez representing the Nevada Disability Peer Action Coalition. I echo the prior speakers, and we do support item L and K. And thank you so much for your valuable time. Take care.
Thank you so much for your comment. Are there other folks on the public comment line?
Hello, this is Jay Colbeck-Clausel for the record from the Nevada Community Health Worker Association. Thank you, Chair Peters and members of the committee for having us today. I will be available to answer questions when item K comes up. But on behalf of the CHW Association, please consider a one-word addition to the recommendation. CHW is a very broad title, and there are CHWs who do not have certification and have staff funding sources that do not require it. Employers have been supporting their staff to pursue the requirements, and we believe that this should be left to market forces to reward CHWs and employers who pursue training and certification. The FQHCs and MCOs are strong advocates for CHW education and certification, so we've seen many of their staff come through our classes even before it was a requirement. Medicaid reimbursement will require CHW certification, and that requirement is appropriate. So with all that in mind, the one-word addition is to add the word certified, so holding himself or herself out as a certified community health worker in this state before, be certified as a community health worker by the Nevada Certification Board. And I'll repeat that since I fumbled. So require that any person holding himself or herself out as a certified community health worker in this state be certified as a community health worker by the Nevada Certification Board. Thank you very much for your time.
Thank you so much for those public comments. I made notes on that suggestion. Are there other callers for public comment?
Thank you, Chair. The public line is open and working. However, there are no other callers wishing to offer public comment at this time. Oh,
thank you so much.
Excuse me, Chair. Sorry, one person did just raise their hand.
Okay, please go ahead and add them.
I'm sorry, I was muted. Good morning, Chair Peters. This is Kevin Dick. I'm the health officer for the Washoe County Health District, and I want to comment on the public health modernization in item L. We saw the consequences of underfunding of our public health infrastructure during COVID-19 And I'm sorry. We saw the underfunding of public health and the impacts during COVID-19. We had health inequities that were magnified, and disadvantaged populations were severely affected. The lack of resources to work with the disadvantaged communities on inequities and health priorities prior to the pandemic left us ill-equipped to work with these communities to provide the support and access to services desperately needed during the always at risk of a new health crisis or emergency.
Mr. Dick, we lost you a little bit there. You're quite muffled.
Adequate, flexible public health funding. For example, we have federal grant funding to administer COVID-19 vaccines to respond to that emergency. Not allowed to use those funds.
Mr. Dick, we cannot.
Callers to our call center seeking the monkeypox vaccine. Have federal funding to visit medical offices, work with physicians and nurses in our community, help them and their staff to understand how to properly store and administer vaccines for children. All the academic detail. But for those nurses, while they're in those physicians' offices, they're not allowed to provide information on how to identify and properly test for monkeypox because the categorical funding they receive can only be used for education, not childhood vaccines. The current funding system we operate in is ineffective and unsuitable for meeting our public health responsibilities. Like going to a doctor who takes you but not weigh you, check your pulse and oxygen levels, or have you stick out your tongue and look down your throat. Categorical funding issues, chronic underfunding of public health. I urge you to approve the BDR for public health modernization, item L, and pass this legislation during the
Thank you for the public comment. We were having a hard time hearing, so hopefully you will submit those comments in writing to our staff so we can include those in the public record. BPS, is there anyone else waiting in the public comment line?
Yes, Chair, there is one other caller. Give me one moment to connect.
BPS, we are not hearing anybody coming in through the speakers. Is it possible that the caller is still muted?
Hi, good morning, Chair Peters. And
please go ahead.
Can you hear me okay? Thank you. Apologies. Thank you for the opportunity to comment on the proposed Public Health Infrastructure and Improvement Fund under item N in the work session document. I am Andrea Gregg, Chief Executive Officer for High Sierra Area Health Education Center, also known as AHEC for the record. I'm a proud alumnus of the University of Nevada, Reno School of Public Health and have spent the last 15 years leading an organization that serves as a critical convener between academic, employer, and community-based partners to really focus on the development, diversity, and distribution of our state's healthcare and public health workforce. We know now more than ever that a sound and sustainable public health infrastructure is an urgent matter for our state. The state's experience over the last 2 years has really demonstrated the need to invest in the public health workforce, as well as build for a future while ensuring that health outcomes improve over the longer term. Finally, the proposed funding and associated investment provides a real opportunity to diversify funding for public health programs in Nevada, which we know would really alleviate some of the reliance on federal financing, which could lead to the dismantling of programs after that funding has been exhausted if sustainability has not been able to be attained. So often the very restrictions that come with federal funding can often leave many of our most vulnerable communities without access to adequate services. Therefore, providing the opportunity for non-categorical and flexible funding will really ensure fundamental public health services are in place and can certainly respond to current and emergent public health needs, as well as improve the health of all communities in Nevada. And then finally, on behalf of our organization, I also echo some of my colleagues on the line and also would like to submit our support for the community health workers, as we know that investments there will also improve our healthcare impact and outcomes overall. Thank you.
Thank you for the comment. BPS, are there other callers on the public comment line?
Yes, Chair, there is one caller with their hand raised. However, they are not responsive. Would you like me to make a note next to their name and we can come back to them during the second public comment?
Yeah, it looks like there's someone in Carson for a public comment that I'm going to go back to as well. So if they do end up responding to you, I'll come back to you after Carson and we'll see if we can get them in this first round. I'm going to go ahead and go down to Carson City. Please state your name for the record and proceed when you're ready.
Good morning, Chair Peters and Interim Health Committee. For the record, my name is Joelle Gutman Dodson, and I'm the Government Affairs Liaison for the Washoe County Health District. Kevin Dick, the Health Officer of Washoe County Health District, was on the phone, but you guys were having trouble hearing him, so I will read what he would have liked to have said into the record. So we're here in support of the Public Health Infrastructure and Improvement Fund. The Public Health Improvement Fund that we've been working on for several sessions now is desperately in need after so many years of underfunding of our public health agencies. We saw the dire consequences of this during the COVID-19 pandemic. Health inequities were magnified and disadvantaged populations were the most severely affected. The lack of resources to work with these communities historically on inequities and health priorities identified in our public health needs assessment left us ill-equipped to work with these communities to provide the support and access to services they so desperately needed. And as you know, we are always at risk of a new public health crisis or emergency. Right now, we're facing monkeypox and again are hindered by the lack of adequate and flexible public health funding. I wanted to give you a couple examples. We have a federal funding grant right now to administer COVID-19 vaccines to respond to that emergency, but we are not allowed to use those funds to administer monkeypox vaccines or even to assist callers to our call center seeking the monkeypox vaccine. We have federal funding to visit medical offices and work with physicians and nurses in our community to help them and their staff to understand how to properly store and administer vaccines for children. This is called academic detailing, but those same nurses, while they are in those physician offices, are not allowed to provide information and education on how to identify or properly test for monkeypox because the categorical funding they receive can only be used for education about childhood vaccines. The current funding system we operate in is ineffective and unsuitable for meeting our public health responsibilities. It's like going to a doctor who could take your temperature but not weigh you, check your pulse and oxygen levels, or have you stick your tongue out and look down your throat, but not look at your ears. We need to fix this categorical funding issue and the chronic underfunding of public health. Thank you.
Thank you for those comments. BPS, were you able to connect with that other caller?
Yes, Chair, they are connected and unmuted. Caller with the last three digits, 237, you may begin.
Thank you, Madam Chair and members of the committee. My name is Marlene Lockard, and I represent SEIU 1107. The largest union of healthcare and public workers in Nevada. Thank you for this opportunity to report on the progress of SB 340, approved last session. I am pleased to report that the committee is operating as intended for the first time in the state's history. This legislation has brought together representatives of home care providers, recipients, and employees to discuss and find solutions for the myriad of issues that have contributed to the low wages, poor working conditions, and the chronic shortage of home care workers in Nevada. Just about a year ago, the Gwen Center issued an assessment of the personal care workforce in Nevada, reporting that a dire crisis was on the horizon, creating a dangerous home care worker shortage, which will hurt Nevada seniors, people with disabilities, and home care workers alike. To compound an already simmering public policy time bomb, Elders Count indicates Nevada has been and will continue to experience an aging tsunami. Nevada's population has increased by more than 11.42%, while the 65 and older population increased by 40%. Nevada's growth rate for age 85 and older is double the national rate. There are approximately 13,000 personal care aides who assist elderly and physically disabled Nevadans with the daily living tasks, such as bathing, eating, toileting, and mobility in their client's home. This workforce is disproportionately women of color who are currently paid an average only of $11 an hour, with few to no benefits. Close to half of the workforce relies on some form of public assistance because of low wages and inconsistent hours. Home care workers play a critical role in keeping seniors and adults with disabilities out of expensive and less desirable care settings. For example, Nevada saves an average of $70,000 a year for every senior who is served through the Frail Elderly Home and Community-Based Waiver Program instead of a nursing facility. Despite the important role that home care workers play, which has been made all the more evident during the COVID pandemic, the home care industry suffers from over 50% turnover rate due to the lack of compensation and respect afforded to these women. Lastly, the vast majority of home care in Nevada and nationally is delivered through Medicaid. Most individuals needing care cannot afford to pay out of pocket. As such, the state, through its role of setting reimbursement rates and other Medicaid policies, is responsible for setting employment and working conditions for the home care industry at large. I would like to commend you and the 2021 legislature for having the foresight to enact legislation to immediately address these critical issues. And I am speaking to item M and asking for your support of the recommendations that have been adopted to date by the Workforce Employment Board. Deputy Administrator Cody Finney has been tasked to chair the Home Care Employment Standards Board, and I know she will be available to answer any other questions during that item. Thank you very much. I appreciate your time.
Thank you, Ms. Lockhart. We appreciate you calling in to give us a brief update on that, the status of that committee, and we look forward to hearing more about those recommendations in the coming session as well. Are there any other callers? I don't see anybody coming to the tables. BPS, do we have anyone else on the public comment line?
No, Chair. The public line is open and working. However, there are no other callers wishing to offer public comment at this time.
Thank you. Thank you so much. We'll go ahead and close out that first public comment. Thank you for all of those who provided public comment. We appreciate you being here today with us. We'll move ahead on to agenda item 3, approval of meeting minutes for the meeting on May 19th, 2022. Members of the committee, are there any questions regarding these minutes? Seeing none, I will entertain a motion to approve the minutes of the committee meeting on May 19th, 2022. I have a motion from Senator Doñate, Vice Chair Doñate. Do I have a second from Senator Harris? Are there any comments or discussion on the motion before we vote? All in favor, please say aye or raise your hand. Aye. Any opposed? Thank you. The motion carries with those present. We'll close out agenda item 3 and move on to agenda item 4, consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B.225. I'm going to go ahead and ask staff to go through these for us as listed in the agenda. I just want to remind the committee, though, that this is informational only. Staff has informed you about the status of the regulatory process of the regulations that we are now considering. If you have a greater interest in participating in the development of these regulations, the process can be found on the LCB website, or you can reach out to our staff for additional assistance. Committee review is an important process for follow-up on bills that we have passed in the last couple of sessions, but we will not be taking any action on these items today. I want to note this committee neither approves nor denies any of the regulations before you today. Instead, each board adopts its own regulations followed by approval through the Legislative Commission. The HHS committee's consideration of these regulations is only from an advisory perspective. If you need further detail, you can please reach out to LCB staff or those boards, regulatory boards. Okay, I'm going to go ahead and ask Mr. Robbins to go through the list of regulations for consideration today.
Yes, Eric Robbins for the record from LCB Legal. So there are 6 regulations that the committee is considering today. There is LCB file RO10-22 and LCB file RO94-22, both of the State Board of Health. There's R026-22, which is being considered by the State Board of Oriental Medicine. There is RO57-22 of the Board of Examiners for Marriage and Family Therapists and Clinical Professional Counselors. And lastly, 2 regulations of the State Board of Pharmacy, RO85-22 and RO86-22. I believe we have representatives of each agency available if members of the committee have questions on the regulations.
Thank you so much, Mr. Robbins. Is there anybody who has questions on the committee on these regulations? I believe Dr. Titus does. Please go ahead.
Thank you, Madam Chair. I appreciate the opportunity to ask a brief question on, and this is in regards to R010-22 of the State Board of Health. And I was just wondering the penalty fees, wondering how they were set if someone doesn't report. This is regarding the cancer reporting.
Hi, this is Andrea Oguchi. I am the program manager for the Nevada Central Cancer Registry. And the fees were actually just a clarification to what is already currently in regulation. So working with our stakeholders, including the Nevada Hospital Association and the Nevada Rural Health Partners, we realized that there was quite a bit of confusion as to what those fees were, because we also have in regulations an abstract fee that was placed there, prior to even looking to amend these regulations.
Okay, thank you. Because again, there's a fee for not reporting, but then there's a fee when you report, and just per facility, I just need some clarification. So thank you. I have no further questions on that particular one, unless somebody else does.
Are there any other questions for the State Board of Health?
I have another question on one of the other regs.
On the second set, go ahead, please ask.
So this is on 09422 on the music therapy, and I'm just wondering why. Why is there an issue with this? Has it been abused? Why are we again regulating music therapy? And is it because they're billing for their services, so it requires some regulation and certification? I just think we have so many licenses that we require in our state. It's more of a hindrance to care than helpful care. So can you explain me just briefly perhaps why this was recommended? Where's the problem we're trying to solve?
Hi, this is Letitia Metherell. For the record, So the licensing of music therapists is actually a statutory requirement. So we have to license music therapists. NRS 640D.10010, the legislative declaration, notice that the practice of music therapy is hereby declared to be a learned allied health profession, and it's needed to protect the public from the practice of music therapy. So that's why we license them, because it's in statutes. We have no choice. As far as the regulations, Section 1 is a requirement due to NRS 622.087. That was AB 330 that I believe passed in the last legislative session that applied to occupational licensing boards. And since music therapist is an occupational licensing board, it also applied. The other ones were existing regulations that were developed as a result of the statutory requirement to license music therapists. And so just this cleaned up the language a little bit to make it more efficient and effective, since it's something we already have to do.
Okay, thank you. Thank you, Madam Chair.
Thank you, Dr. Titus, for the questions. And on the music therapy piece, I had an opportunity to go and visit with the notables in Reno. If you are up in that area and would like to get a perspective on what music therapists do and how they impact our community, I would encourage you to reach out to them and see about a visit and a chat. Are there any other questions on the regulations presented today? All right, I'm going to go ahead and close out that agenda item and move on to our first presentation agenda item today, agenda item 5, presentation regarding priorities and recommendations of the Regional Behavioral Health Policy Boards during the 2021-22 legislative interim. We have 1, 2, 3, 4, five boards to present on their BDR ideas today. I believe we have one up in, I was going to start with Clark. Are you? Okay, perfect. Okay, please go ahead, introduce yourself and proceed when you're ready.
Thank you.
I believe that intros in Carson. Thank you so much.
Thank you, Chair Peters and members of the committee. For the record, this is Valerie Haskin, Rural Regional Behavioral Health Coordinator. Bear with me for just a moment while I get the presentation up and running. So thank you for this opportunity to speak to you today. I'm going to open our series of presentations with a brief description and overview of the Regional Behavioral Health Policy Boards to provide some context for the following presentations from each of the coordinators. The Regional Behavioral Health Policy Boards were established during the 2017 legislative session by AB 366, and in 2019, AB 76 further divided the state into 5 behavioral health regions. This was done to ensure that regional boundaries were based on common access to services and needs. Each Regional Behavioral Health Policy Board consists of 7 to 13 volunteer members and represents a broad group of stakeholders from local communities, including law enforcement, human or social services, behavioral health providers, the criminal justice system, system consumers or family members, insurers, emergency services, and others. Appointments to the board are made by various bodies, including the governor, the Senate Majority Leader, the Speaker of the Assembly, the Administrator of the Division of Public and Behavioral Health, and other board members. Due to time constraints, I'm not going to go into great detail regarding the duties of the boards. However, the board's duties do include advising the Nevada Department of Health and Human Services and all of its subdivisions, as well as the Commission on Behavioral Health regarding the needs, assets, and progress related to behavioral health in each region. The policy boards also provide state agencies with local insight to help them prioritize funding in a way that may have the greatest positive impact. The boards also provide additional insight as to any obsolete, redundant, or otherwise problematic legislation or public policy that creates barriers or other challenges to improving the behavioral health system. Through this work and other efforts, the boards aim to promote improvements in the delivery of services, both on the part of DHHS subdivisions and private providers. As stated in NRS 433.4295, the boards must also maintain a repository for behavioral health data, and this is currently done through the All Boards website, which can be found at nvbh.org. Finally, the boards work to improve communication and collaboration among state and local agencies. For a comprehensive list of these duties, please see the handout provided, which also includes the full language of NRS 433.4295. After the creation of the Regional Behavioral Health Policy Boards, the Division of Public and Behavioral Health created the Regional Behavioral Health Coordinator positions, held by my counterparts and I. We act as the unofficial staff for each of our respective boards and complete not only the administrative duties for the board itself, but also, more importantly, we work as liaisons between state and local agencies within our respective regions to build capacity and improve various areas of the behavioral health system. This work may include addressing challenges to community members trying to access behavioral health treatment, assisting with projects that provide education and training for organizations and community members looking at state and local level data and reporting processes, and seeing how we can assist in improving these processes. We also assist with the coordination and communication regarding available services that are provided by the state and other local agencies within the region to minimize duplication and to fill gaps as best we are able. We are also used as a means of communicating local needs and behavioral health status up to state agencies, as well as communicating state plans back down to the local level. Now I would like to take a couple of moments to introduce each region and their respective coordinators and chairs. The Washoe Regional Behavioral Health Policy Board's region includes Washoe County only. Their chair is Julia Ratty, and their coordinator is Dorothy Edwards. The Northern Regional Behavioral Health Policy Board service area includes Carson City, Story, Churchill, Lyon, and Douglas counties, and is chaired by Taylor Allison. Sherilyn Raller-Wood recently joined our ranks as the coordinator for the Northern Board, replacing Jessica Abris. Next, I'd like to introduce my favorite, the Rural Regional Behavioral Health Policy Board, which represents Pershing, Lander, Humboldt, Eureka, Elko, and White Pine counties. The board is chaired by Fergus Loffridge, and I have the honor of serving as the board's coordinator. The Clark Regional Behavioral Health Policy Board represents the southern tip of Nye County and all of Clark County. It is chaired by Shar Frost, and its coordinator is Michelle Bennett. Last but not least, we have the Southern Regional Behavioral Health Policy Board, which serves Mineral, Esmeralda, Lincoln, and Northern Nye County. Kim Donahue is their coordinator, and their chair is currently pending. Their first meeting is scheduled for next week, so there are some exciting things to come and to expect from the Southern Board. So in conclusion of this very brief overview, much more detail regarding the boards, their priorities, and their respective BDR topic areas will be given within the presentations to follow. Additionally, more details about the boards, their roles, and activities can be found in the handouts provided to support this and the region-specific presentations. Thank you.
Thank you for the brief presentation. I have to say I serve on the Washoe Regional Behavioral Health Policy Board, and I really love the work that we do and the group of folks that are brought together through these boards. And I just wanted to share that. I think we have a couple of folks on the committee who serve on these boards. So thank you for being here today. I will go ahead and let you proceed with the next part of your presentation.
Thank you, Michelle Bennett, for the record. I do have the presentation up over here. Is it reflecting on the screen? Okay.
We can see it in Clark County. Can you see it in Carson City and online? Okay, we've got thumbs up from Dr. Orentlicker. I got head shakes in Carson City. Dr. Titus, would you let me know when you're able to see?
Chair, we can see it. Thank you.
Wonderful. Thank you. Please proceed.
Good morning, Chair Peters and Vice Chair Genante and committee members. My name is Michelle Bennett, Clark Regional Behavioral Health Coordinator. Thank you for the opportunity.
Yes.
Madam Chair, I can see a teeny weeny little screen. So if there's a way to make it a bigger screen.
We have some screen sharing going on. BPS, would you let me know when that is corrected? It is also online, Dr. Hardy, if you have access to LCB's website or the legislative website, you can also see these presentations online.
Right. Thank you.
All right, please go ahead and proceed.
Again, Michelle Bennett for the record. Thank you for the opportunity to present today on the Clark region. The Clark Board is currently filled with all positions and a strong representation of professionals in this region. In addition, board members participate, in addition to their day jobs, they volunteer their time and participate in various coalitions, committees, and boards across the entire state and bring that expertise to tackle the complicated issues in behavioral health. I am pleased that the board members possess a high level of cooperation and teamwork. There is also a strong community interest in any vacancy that is available. Following a time of global turmoil, the board recognizes organizations are doing their best to serve the community while evaluating every aspect of their business operations to stay afloat. This has resulted in an acceleration of existing challenges, and this board will reevaluate priorities during the September board meeting. For the exception of the last priority to identify wraparound services for individuals experiencing homelessness and mental health crisis, all other priorities predate COVID challenges. The goal is to build better resilience for consumers and service providers with a commitment to creating sustainable value. The board acknowledges increased service provider scrutiny and stakeholder consideration, is prepared to adjust the listed priorities to serve the community better. Some of the regional challenges Clark faces echo many of what the state challenges are. This is just brief bullet points of some of the challenges. Clark is currently the second largest county to experience, it has a high percentage of severe depression and frequent suicide ideation, and that's among all other U.S. large counties. Workforce shortages, which you will hear throughout the presentations of my coworkers and other coordinators, is a common theme. This affects access to care, treatment, and proper diagnosis. Clark County Detention Center is the largest mental health provider by patient in volume. They average about 21,000 inmate populations with a behavioral health need. However, there are some positives being done. And I want to highlight Las Vegas Metro. They are probably the first to bring somebody into the system, and they are doing their best to reduce arrest and get people into the proper treatment. Some of their attempts are the creation and facilitation of hot teams, which provide outreach to individuals who are experiencing homelessness and connecting them to resources. A lot of times this is the first point of contact that somebody in our community will have into entering the system. CIT crisis intervention, they are actually doing some great stuff. They are working with Clark County Social Services, so many acronyms, working with social workers. So these social workers are going out with police officers and they're responding to crisis calls. It reduced arrest, incarcerations, and helps those suffering from mental illness to get into services that they need. And then finally, I want to highlight the Lima program, the Law Enforcement Intervention for Mental Health and Addiction. This is through the Office of Community Engagement. This is a diversion program. It's a 9 to 12 month pre-booking program that is geared towards helping people with low-level drug offenses. The key thing about this is participants must have a chemical dependency, but they're willing to engage in treatment. So throughout their participation in Lima, they are connected with resources, skill levels, sometimes even a reevaluation of what their job skills are. And this program currently has 300 referrals. They have 60 graduates to date, and the recidivism rate for their graduates is only 3%. So they are doing good work. One of the main challenges that all of these programs are reporting back is a lack of affordable housing and mental health facilities to treat this population. Left with no other options, many times these individuals either disappear from contact or they repeat offenses. So they've achieved remarkable success. But along with numerous community partners, they need help, which leads me to the Clark Regional Behavioral Health Policy Board BDR concept for the upcoming session. In July, the board voted to approve the development of a supportive service transformational fund. A key component of this is supportive housing. So since many of these individuals are trying to get into treatment or unable to sustain themselves, they often need a third party to help them sustain whatever goal or mental service that they need. So supportive housing is a concept that engages rental assistance and supportive services, wraparound services that can help with case management, care coordination in order to get somebody in a place where they can function at the most successful rate. So renting assistance is not enough for this population. Since supportive housing is a primary concept, the development of the fund will provide affordable housing on a short-term and permanent basis to individuals in treatment and recovery from substance addiction to persons with moderate to severe mental illness, including chronically homeless and individuals with intellectual and developmental disabilities. In order to encourage a cohesive service system across service sectors and maximize available resources, it is important to align services across the range of providers that includes intellectual and developmental disabilities, the justice system, aging, homeless response, behavioral health, child welfare, and youth. All these linkages to affordable housing are alternatives to facility-based care and will maximize dollars because individuals are tapping into one source and not having to go across multiple sources to get their housing completed. That's all I have for today. Thank you for letting me present.
Thank you so much, Ms. Bennett. Can you say the name of the fund, what you guys have come up with as the name of the fund again?
Transformation Fund. And I do get a lot of questions on that, so we're developing the language on that.
Oh, great. We look forward to hearing more about how you guys build that out and what it will start to look like before session starts. Are there any questions from the committee for Clark Regional Behavioral Health Policy Board? Can't see Carson City, so Dr. Titus, please speak up if you have a question.
No, I'm good. Thank you.
All right. Thank you. I think that we're okay right now. If you want to stick around to the end in case questions come up based on these other ones, that would be great. I think our next presenter looks to be the Northern Regional Behavioral Health Policy Board. I'm not seeing them in Las Vegas.
They're at the table here.
Can't see Clark.
They're here.
Okay, perfect. Please introduce yourself and proceed when you're ready.
Good morning, Madam Chair Peters and members of the committee. As Valerie mentioned in the introduction, my name is Sherilyn Rawood, and I'm the Northern Regional Behavioral Health Coordinator. Thank you for the opportunity to provide my presentation on agenda number 5B regarding priorities and recommendations of the Regional Behavioral Health Policy Board. Today, I'm in my 9th week in this position, so I apologize up front if I miss anything that should be reported to the committee. Please note, Chair and committee, I can supply any further necessary information if needed. A little bit about the Northern Region. As Valerie said, it consists of Carson, Churchill, Douglas, Lyon, and Story counties. The current population is estimated to be reaching 200,000. The total area is approximately 8,049 miles of rural and frontier, and in actuality, the area is 11,976.95 square miles. I just recently learned this. When looking at the ethnic makeup of the Northern Region, 74.1% of the residents in the region are white, not of Hispanic origin, 16.6% are Hispanic, 3.2% of the population are Native American, 2.4% Asian, and 1.9% of the population are Black or African American. Looking at the age differential, 5% of the population is under 5 years, 22% is between the ages of 5 and 24 years, 23% between the ages of 25 and 44 years, 28% between 45 and 65 years of age, and then 23% are of 65 and older. There are approximately 19,400 veterans that reside in this region as of 2020. I would like to offer you some other prevalent data points important to the overall behavioral health of the Northern Region. Lyon County experienced the highest increase in methamphetamine-related deaths from 2.0 per 100,000 211 to 2.2 per 100,000 in 2020. In 2020, the Northern Region suffered 64 losses to suicide. Persons living in poverty by percentage in 2019 were 10.6%, and a significant increase in the percentage of Northern Region residents who reported 10 or more days of poor mental health had an increase from 16.4 in 2018 to 26.9 in 2019. Anxiety has been the leading mental health-related diagnosis since 2020 in emergency department encounters, and anxiety-related encounters increased significantly from 2019 to 2021 in both counts and rates. Depression is the leading diagnosis for inpatient admissions in the Northern Region, and ED visits for marijuana, opioids, and heroin increased from 2018 to 2019. Just some of the statistics that this board has to work with as of right now. So in accordance with NRS 433.429, I would like to introduce you to the Northern Regional Policy Board. Chair Taylor Allison, representative from a community-based organization providing behavioral health services. Vice Chair Dr. Ali Bannister, representative of the criminal justice system. Dr. Robin Titus, our legislator. Dr. Amy Hines Sutherland, representative of hospitals, residential long-term care facilities, or acute inpatient behavioral health facilities. Nikki Aker, a county health officer or their representative or similar public health position from city, county, or tribe. Eric Schoen, member who represents interest of administrators or counselors at facilities for the treatment of alcohol or drug abuse. Sheriff Ken Furlong, representative of law enforcement with knowledge and experience with persons needing behavioral health services. Sandy Workow, DEMHS member who represents providers of emergency medical services. Lana Robards, representative of residential treatment facility, transitional housing, or other housing program serving persons with mental illness or who abuse alcohol or drugs. Dr. Amy Kegels, our licensed Nevada clinical psychiatrist. Shayla Holmes, person with extensive experience in behavioral health delivering, including without limitation, social services agent directors. And Laura Yanez, our peer or family advocate. So looking at some of the board's areas of discussion and support, our behavioral health workforce across the Northern Region is lacking. I believe the consensus on this topic is that it's a hot one statewide. You're going to hear that a lot today, probably from each coordinator. Regional board infrastructure, the security and sustainability of it, the insufficiency of coordinated behavioral health responses to those in crisis. Training and crisis planning must be continued to be developed and providers trained. Crisis response 988 are being built up upon to help close these gaps while we are a few years away from more optimal services. These deficits to the crisis response model need to be addressed now. Access to care for all ages and levels of treatments. This will continue to be a problem if the workforce issues aren't resolved, as well as transportation issues within my region. Lack of behavioral health supporting houses for SMI and SUD population. Board will continue to reach across the county lines to work on this statewide issue as we move forward. Transportation in accessing medical care and mental health crisis. Transportation is a gap and a huge barrier throughout our great state, and that's another hot topic you're going to hear talked about quite a bit. And finally, consistent community awareness or knowledge of state and local programs across the entire region. That being said, there is always hope, so I'd like to focus on some positive assets of the Northern Region. As the newbie, I've been in awe at how these counties truly come together. The resiliency from the Northern Region is unwavering, and I would be remiss if I did not highlight some of the successful projects and programs that reign in the Northern Region. We have our MOST teams, our mobile outreach safety teams, and we have those in Carson, Douglas, and Lying, and they are growing bigger and better and stronger as 988 and the crisis response model gets built up. We regional FAST programs, those are multidisciplinary forensic assessment service triage teams, and they work with incarcerated individuals being released by offering alternative ways for treatment, services, and resources. CIT program, our crisis intervention training that occurs in most of our northern counties with our community partners and law enforcement, and I am blessed to be able to train within some of those CIT trainings, and great response and from our law enforcement. Multidisciplinary teams, or MDTs, for individuals with SMI cases that struggle with regular traditional services. These teams are vital when it comes to our most severe SMI population. Working together, they provide that extra special assistance for treatment or need that sometimes warrants a bigger team to figure out. And finally, the Northern Region's local behavioral task force teams. Every one of the Northern Region counties has a behavioral Behavioral Health Task Force. I have had the honor of sitting in on a couple of the county's meetings and so far, and I would say these are vital in bringing a nice array of partners from the surrounding communities and counties together at the same table, using their voices to talk about current issues in the surrounding areas, giving updates on the old and new resources and programs, things of this nature. Very informative and active. So thank you for the pleasure of allowing me to give you an idea of the assets that I've learned from this region as I'm settling in. Lastly, here's a bit of the board's recent history as well as the focus of their BDR concerning legislative priorities impacting behavioral health. The board has been and will continue to provide support, testimonies, intra-regional legislative support, education, and advocacy as always and ongoing. During the 81st legislation session, the board's BDR was rewriting the NRS 433 language and changing not only the legal holds titled now Mental Health Crisis Hold, but really focused on other language, giving persons who are at risk a sense of dignity and a voice. I can speak to the Northern Regional Board's new BDR that the board will be writing, and that is the Regional Behavioral Health Authority. The board is in the works of writing the language for the BDR, so I can't elaborate too much, but to say that there is there's a little bit of the why on the one-pager that I've provided, and I noted the other BDRs on the boards with a focus, and I apologize, Dorothy, that I forgot to put your BDR on there. I know, my bad. In conclusion, I want to thank you for all the time today in hearing what is happening with the behavioral health-wise in Northern Region.
Thank you so much for the presentation. Are there any questions on the Northern Regional Behavioral Health Policy Board? So many acronyms, you guys. I don't see any questions coming in from committee members. Thank you so much for the presentation. We look forward to seeing how you flesh out that BDR language, and it may be worth coordinating a little bit based on some of our work session documents today on that language.
Madam Chair,
Oh, please go ahead, Dr. Hardy.
I guess the chat symbol of raising hand doesn't work.
I cannot see you all the time, so I appreciate you just popping in. Thank you.
So I was intrigued. I'm not sure I'm going to get an answer because I don't know if an answer is available, but in the world of medicine, we find anxiety very common. And what's happening now is the insurance companies are in the process of trying to say that we're not allowed to bill for the treatment of anxiety. And so I think that one of the challenges that we're going to see is we're going to see more people trying to be less anxious without the help of their insurance, and therefore they're going to be looking for other sources to be able to treat anxiety. So I don't know if that's playing a role that people are seeing in Northern Nevada, but it's obviously concerning if we see their greatest diagnosis of anxiety and on some circles we're not allowed to treat it or get paid for it, rather. Has that been something that we see up there?
Senator Artie, I can't speak to that question right now, but I'll get some information.
Would you identify yourself again, please?
Oh, yeah. Sherilyn Rahr for the record. Senator Hardy, I can't speak to that answer right now. I haven't really looked into that recently, 9 weeks on the job, but I can go ahead and do some research on that and get back to you if necessary.
Appreciate it. Thank you. Thank you, Madam Chair.
Thank you for that question, and that is disturbing to hear, considering I think many of us, particularly of my generation, anxiety is one of the only things that takes us into our doctor's offices. So I think there's probably some legwork to be done around that. Thank you for bringing that to our attention as well. Are there any other questions for the Northern Regional Behavioral Health Policy Board? I'm not seeing any. Thank you so much. If you don't mind, again, sticking around for a little while in case questions arise from these other presentations, that would be fantastic. I have next on my list Ms. Haskin with the Rural Regional Behavioral Health Policy Board. It looks like you are in Carson City. Please introduce yourself and proceed when you're ready.
Hello again, Chair Peters and members of the committee. Again, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. And now it's my turn to give you a brief overview of the Rural Board's priorities and BDR topic area. I'm not going to go into any detail regarding the demographics of our region, just for the sake of time, but that information can be found on the handout that was provided. For 2022, the Rural Regional Behavioral Health Policy Board decided to organize its priorities into tiers, the logic being that Tier 1 priorities are those that might have the highest positive impact on the behavioral health system and will also affect Tier 2 and Tier 3 priorities. These Tier 1 priorities include workforce development, improved, safe, and effective transportation options both to and from crisis and non-crisis behavioral health services, improved access to age-appropriate care across the service spectrum that would specifically target those who are youth as well as our elderly, and improved reimbursement for services, both from public and private insurers. Tier 2 priorities are those that are important but are seen as heavily affected by changes in Tier 1 priorities. The Rural Board's Tier 2 priorities include improved care transitions and communication among providers across the statewide behavioral health system, improved safeguards to ensure that the care provided to our communities is of high quality, and improved access to mid-level care, which seems to be a statewide gap. Tier 3 priorities include improving access to care for active duty service members, veterans, and their families, or SMVF, expanding the availability of culturally appropriate and respectful services and programs, leveraging telebehavioral health care for services as appropriate, and finally, stigma reduction. For more detail regarding these priorities, again, please see the handout provided. Oh, probably be helpful if I put this in the right format. There we go. All right, at its June meeting, the Rural Regional Behavioral Health Policy Board voted to adopt the building of a robust pipeline to bolster Nevada's behavioral health provider pool as its BDR topic for the 2023 legislative session. These slides, as I move forward, will say draft, as these concepts are currently subject to change upon board approval at its meeting next week. The ideas presented here have been developed through conversations with stakeholders across the behavioral health system and are advised by the work of Dr. Sarah Hunt at UNLV, who has committed a great deal of time researching these pipeline models. This Nevada pipeline would be based upon successful models from Nebraska and Illinois, and it's my understanding that other states are also looking into adopting similar models. Like these other states, the Nevada pipeline model would likely include the launch of a behavioral health workforce pipeline center, which would collaborate with and help expand upon existing successful programs, so there's no desire to create any sort of duplication of efforts, but would introduce new programs and connections across the educational system and occupational licensing works, going from K-12 education through professional practice. The types of providers currently intended to be targeted in this model include clinical social workers, marriage and family therapists, clinical professional counselors, psychologists, psychiatrists, and all drug, alcohol, and gambling counselor types. For the sake of conversation, we are currently defining underserved, as you'll see in these next few slides, as rural, frontier, BIPOC, LGBTQ+, and other minority communities. The first component of the behavioral health workforce pipeline is K-12 education. Here, the board and its stakeholders would love to see expansions of career and technical education programs across the state to be consistent and robust, regardless of location, and of course to include opportunities for students to learn about behavioral health professions. Additionally, the center would collaborate with successful programs such as the Area Health Education Centers, or AHECs, which provide support and guidance to high school and college students who want to pursue health careers. Here, the center would support the AHECs across the state in expanding their efforts to include behavioral health professions. The efforts of the pipeline at the K-12 level should also be focused on supporting minority youth and those who are otherwise disadvantaged in pursuing careers in behavioral health. And lastly, it is intended that efforts of the center would be interwoven with or support existing social and emotional learning and suicide prevention programs at our school districts. The next segment of the pipeline would focus on both the institutions within the Nevada system of higher education and the colleges and universities that may serve Nevadans but sit outside the NC system, such as online college programs. Here, the center would help ensure that undergraduate students are fully prepared for the rigors of graduate school and would help those students navigate the coursework and testing requirements to successfully apply for their chosen programs. Much of this work is already being done by the area health education centers, but the intention here is to help support and expand these efforts further into behavioral health. One of the center's objectives would be to work with higher education students to ensure that easily accessible opportunities for students to access internships are readily available, both during graduate school and for postgraduate clinical experience. This would include the expansion of approved supervision sites, increase the number of approved supervisors through training and active recruitment, and would streamline approval processes for these internship opportunities between the schools and the licensing boards. Additionally, there would be a focus on creating these opportunities for students specifically to gain experience working with underserved communities and special populations across Nevada. Next, the center's pipeline efforts would focus on assisting the occupational licensing boards as needed, with further streamlining their processes and keeping their communications with applicants clear and consistent. This may include that ensuring that the licensing boards, who are not already doing so, are focusing their efforts to improve efficiency relating to application processes for both applicants from Nevada and those from out of state seeking licensure by endorsement, reciprocity, or preferably interstate compact. Finally, while professional practice is at the tail end of this pipeline, most of the efforts listed here would be interwoven through the course of earlier components. This would include working with the Nevada Health Corps and related federal or state programs to help place providers in underserved communities, while also assisting new providers with student loan forgiveness or repayment programs. Additionally, the pipeline's programs would include programming to help new providers understand the business side of professional practice. Finally, it is intended that the providers who have benefited from the pipeline's programs would be recruited and trained as supervisors or preceptors for other students to complete their internships or clinical hours, thus coming full circle. Again, the concepts presented to you in this presentation today have not yet been voted upon for inclusion by the Rural Board, and they are still subject to change. However, we are definitely open to any suggestions or ideas that could strengthen this concept or program. Thank you.
Thank you so much for the presentation. Can I just summarize this, that you guys are looking at a pipeline support center and partnering with other agencies? Is that kind of the intention of it? You kept saying center, so I was...
Yes.
Okay.
For the record, Valerie Haskin, Regional Behavioral Health Coordinator. So the models from Nebraska and Illinois both focus on having a center that is housed within the one or more, I think it's 2 or 3 for both of them, and institutions of higher education within their respective systems. And with that, it's kind of, I don't want to say forcing, but it kind of like pulls the different programs at all of the different locations of the NG system, well, it would be NG here in Nevada, together so that they have to work collaboratively and kind of ensuring that communication. One of the big pieces is looking at that internship piece so that we can make sure that people who are graduating have internships to move on to, which is a major issue that we've seen as that my board has seen and that I have also seen as the regional coordinator with people having a difficult time finding placement. So that kind of within graduate school to postgraduate and licensing would be the major focus. Again, we wouldn't want to duplicate any efforts, but kind of really need to pull all of these different agencies and organizations together.
Thank you for the clarification. Are there any other questions from the committee?
Madam Chair?
Not seeing any. Oh, yep, please, Dr. Titus.
Thank you. Thank you for the opportunity to ask a question. Thank you for your presentation. Just some clarification. So I was a product of my county paying my way through school, went back after medical school and had medical students and residents rotate with me from the very first day I opened my doors and continued for about 38 years. But again, you mentioned about duplication of efforts, and how much time have you invested in our meeting with the School of Medicine's residency program in Winnemucca that's already there, looking at putting something in Elko, and so just wondering what coordination have you brought them to the table when you've discussed this bill already?
For the record, Valerie Haskin. The School of Medicine, no, not necessarily, simply because the professions that are focused on here are outside of the scope of the Board of Medical Examiners, except for psychiatrists, which is a new professional focus for my board. We have previously focused on clinical social workers, MFTs, CPCs, and drug and alcohol counselors. So that being said, we have been working, and we've had Gerald Ackerman from the Office of Rural Health, who also oversees the Nevada Health Corps program on our calls and within our strategy meetings. So that's been incredibly helpful. On the behavioral health side, it seems as though there's just less knowledge among students about the opportunities there are to access these programs that can help them. And then one of the issues there is that I believe I've heard from Mr. Ackerman is that they aren't given any funds for marketing. And so having the center would kind of help fill in the gaps between the professionals within each particular program, because people get busy and they get focused on their work, and that happens. But this would kind of help coordinate the education and ensuring the knowledge of the availability of these services and programs.
Thank you for that. And the fact that you have Gerald Ackerman involved gives me much comfort, because Gerald knows his job out there and has done a tremendous job for the rules and understands the layers of all the healthcare folks needed. Have you talked to the superintendent of schools, school districts out there for that pipeline of students to get interested?
I have been working my way through my email list this last week to get emails out. I've also reached out to the NSHE system of higher education.
Perfect. The whole concept of the pipeline, the whole concept of the whole umbrella of healthcare workers, and you have to grow your own to get these kids to come back to these rural areas. So I certainly like the concept, and again, the fact that Gerald is involved gives me some good confidence that you're going to have some good direction on how to do this, and not just. It always sounds great, but then when it comes to fruition or trying to implement it and not repeat stuff and look for monies for that, and using the Nevada Health Corps as part of that program would be good if we can get that funding. So anyway, thank you for what you're doing.
Thank you.
Thank you, Madam Chair.
Thank you so much. It looks like you have a couple of folks in the Senate this time around who are invested in this bill. So I'm looking forward to those conversations and hearing how this pans out for you. Any other questions? Seeing none. Thank you. If you don't mind sticking around for a little bit, we'll move on to our next presentation. I have the Southern Regional Behavioral Health Policy Board, Ms. Donahue. And it looks like you are in Carson City. Please introduce yourself and proceed when you're ready.
I apologize, I am not finding my presentation.
We should have staff in the room who can help you with that.
Oh, there we go. I apologize. Okay. My apologies. Good morning, Madam Chair and members of the committee. My name is Kim Donahue, and I'd love to spell my last name for the record, Donohue. And I'm very excited to be in the position as the Southern Regional Behavioral Health Coordinator. Thank you for the opportunity to provide these updates on the priorities and recommendations of the Southern Regional Behavioral Health Policy Board. I believe it is important for me to stop and make note that the Southern Regional Behavioral Health Policy Board is not at the same level of the other policy boards. It's important for me to mention that in the introduction from my counterpart, that the policy board for the Southern region was developed in the 2019 legislation, and this position had been vacant for over 3 years before resuming this role. The board had not been able to successfully form a full board and hold a quorum in the past. On January 3rd of 2022, I accepted the role as the Southern Regional Behavioral Health Coordinator. I cover Mineral, Esmeralda, Northern, Nye from the 38th parallel, which is from Tonopah up to the Duckwater Reservation, and Lincoln counties. I cover approximately 26,000 square miles of Nevada, and looking at the data, the population is estimated to be between 13,888 and 16,000. I've pulled this data from the United States 2020 Census Bureau and also from the Nevada Department of Taxation. So there's a little bit of, it's hard because Nye County is divided between two coordinators, between myself and the Clark Regional Behavioral Health Coordinator. So with having that county divided, it does make those populations and those that I serve and the square mileage a little difficult to narrow down precisely, but I have done my best. The ethnicity breakdown has also been provided to best understand the community's makeup that encompasses the southern region. On July 28th of 2022, from 9 a.m. to around 11, the Southern Regional Behavioral Health Policy Board met to hold the first scheduled policy board meeting. We had 30 online and 50 in person in attendance. However, due to a technical difficulty, the Deputy Attorney General respectfully requested the meeting be ended in order for us to comply with open meeting law. We then rescheduled our meeting, and so I do have 7 board members appointed, and I would like to announce that Franklin Katchke, our public defender out of Lincoln County, has been assigned to the board. Sheriff Carrie Lee out of Lincoln County, excuse me, Dr. Kevin Austin Gardner out of Adler University with Community Health Services, practicing in both Las Vegas and in British Columbia. I also have the honor of having Assemblyman Gregory Hafen II assigned to the board. I have Missy Rowe. She's the CEO administrator of one of the hospitals in my region. It's Grover C. Dills Medical Center in Lincoln County. I have Stacy Smith. She is the Nye Communities Coalition Executive Director and will be filling the role of our Drug and Alcohol Facility Administrator Representative. And lastly, I have Chief Scott Lewis out of the Pahrump Valley Fire and Rescue Services. These 7 board members bring a wealth of knowledge and experience, many holding over 25 years of experience in their current position. On the August 22nd board meeting, we will be voting in the 7 board members will be voting in the 6 open appointed positions. I have those 6 positions available with 8 candidates applying for those positions. I would also like to point out, Madam Chair and members of the committee, I do have one position that does remain open. We are looking for candidates to fill the private or public insurer representative position. This coordinator has requested through Medicaid to help identify a representative that covers the southern region. I also have identified by pulling data and have identified that United Healthcare is one of the largest insurance providers in the southern region. The rescheduled policy board meeting for August 22nd is held hybrid. I hold that through Zoom. Microsoft Teams is not well supported and makes it extremely difficult and provides a lot of barriers for my board members in the southern region, so we use Zoom. And in person, the UNR Extension Office graciously holds in person the insight for the board meeting for those that would like to attend in person. The regularly scheduled reoccurring board meetings have been scheduled for the 4th Thursday of every month from 9 a.m. to adjournment. So we will have our first board meeting the 22nd, followed by Thursday the 25th will be our second board meeting. On the August 25th, we will vote on a bill draft request, or the board will take these next 2 years to prepare for the next session. Since our board has not fully been formally able to hold a meeting until next week, I will allow the board to make that decision. As the Southern Regional Behavioral Health Coordinator, I will be presenting to the board members my findings that I have gathered over the last 8 months in conducting needs assessments and SWOT analysis. SWOT analysis is identifying our strengths, weaknesses, opportunities, and threats within the communities I serve. This information was gathered by holding meetings with my sheriffs, undersheriffs, coalition, hospital CEO administrators, which I have 2 in my region, Mount Grant General Hospital in Mineral County, Grover C. Dills Medical Center in Caliente, Nevada in Lincoln County. I also have met with all of my EMS, fire services, emergency directors, county managers, the statewide coordinators, school superintendents, principals, school counselors, our human service directors, community stakeholders, our tribal partners, and many other statewide agency partners across the state. These findings will help educate and contribute to the board members' areas of focus when determining the board's priorities and possible bill draft request selection. Some of the gaps identified have been consolidated to an informational board introduction and overview document that I have provided in order for the Legislative Council Bureau and those interested to understand the important findings that I've gathered. Here are some of the gaps that I have been able to assemble. Transportation, access to affordable, reliable, reimbursable, non-emergency transportation to medical and behavioral health services that is accessible to the community by phone or online and appropriate to meet their real-life schedules. Access to appropriate emergency behavioral health services that is safe for the patient and the transporter, reducing trauma and stigma and shame, and reduces the impact on the very limited emergency services such as our sheriffs, emergency medical services, and our medical flight staff. Another area that I will be highly discussing with the board is the idea of specialty courts. Increasing specialty courts across Southern region for individuals who might be experiencing severe mental illness, substance use disorders, or also opioid use disorders or co-occurring symptoms to reduce recidivism and increase access to supportive programs and services to provide more successful and sustainable outcomes. Also, to increase supportive housing services with wraparound services to include case management for individuals with severe mental illness or also co-occurring substance use or opioid use disorders. Another gap identified is behavioral health workforce, which you will hear and you have heard. This is a common thread across the state. To increase behavioral health providers and workforce available to treat patients living in rural frontier regions across Nevada. And I would like to note that I feel that most of my region is very frontier, encompassing the southern region. Also to identify the process to improve licensure reciprocity for mental and behavioral health providers, and also to increase youth access and visibility to well-defined career paths in mental, behavioral health, and the public health fields. Another area of gap became very apparent within my first few days of my job. I'm now a little over 8 months into this position. And due to the almost 3-year vacancy of this coordinator position, the community's lack of knowledge and or access of state, federal, and local grassroots programs and services that provide to our youth and elder populations who may be experiencing severe mental illness, substance use disorder, opioid use disorder, or co-occurring disorders. And coordination of communication of emergency services, processes, and procedures in responding to a mental or behavioral health crisis across the southern region. Another gap identified is youth, elder, and family services, the awareness, connection, and support of programs addressing youth behavioral health in schools and at home, the awareness of connection and support for programs addressing elder behavioral health, awareness, connection, and support for new and existing programs that may support wraparound services for individuals and their family members who might be experiencing mental behavioral health challenges, and increasing access to programs and services for individuals with substance use and opioid use disorders. Another area that I have identified that has been a gap, and I have worked very hard in my previous position with the state, as I do in this current position, is building our tribal partnerships across the state. Working with our tribal partners to identify areas of concern on tribal land. In my southern region, I have Walker River Paiute tribe, which falls in Mineral County. I have the Duckwater Shoshone tribe, which falls in northern Nye County. And I have the Yamba tribe, which falls in northern Nye as well, to improve access to our state, federal, and local programs and services to improve the overall health and well-being of Nevada's indigenous population. I wanted to kind of end with the assets because being the positive person, I think we we always focus on what's broken, some of the negativity, and I really would like to draw on some of the assets and strengths across the southern region. Resiliency, top number one. For my frontier communities, they have demonstrated incredible resiliency. The FAST team, we have Nye Community Coalitions has some drivers that have really been supporting our FAST teams, which encompasses, as previously mentioned by my other counterparts, taking our CIT, crisis intervention training, our MOST teams, expanding that. Also, trying to make those more statewide. Instead of regional, making that more statewide and standardized language and processes and procedures. MDT, multiple disciplinary teams. I have also found with my location in the southern region, I am positioned to utilize many of our state agencies and programs, both with our northern teams and our southern teams. So I am supported by the southern regional MDT teams and also northern and southern. Our coalitions, I am very lucky to have several coalitions in the southern region. I have that is where I have found a lot of the strength and a lot of our boots on the ground and been able to have incredible visibility and identification of the strengths, weaknesses, and opportunities across the southern region. Lastly, I would like to say the development of the Behavioral Health Task Force, as also previously mentioned by my counterparts, has been a priority to help bring community stakeholders to one table to discuss and tackle the county's mental and behavioral health concerns, challenges, strengths, and priorities. I was able to form the Mineral County Behavioral Health Task Force. We held our first meeting. It is the first Tuesday of every month from 11:30 to 1:30, and that has had incredible participation and collaboration also with Shannon Erse from Churchill County. So this has just really provided a great avenue. I have plans to expand and develop more behavioral health task force across my region. And lastly, I would like to thank the chair and the members of the committee for the opportunity to provide these updates. If you have any questions, please feel free to contact me at the information provided on the slide. Thank you very much.
Thank you, Ms. Donahue. You have taken on quite the effort over there and really brought in a wealth of information for being there for 8 months. So congratulations on pulling together your committee, or your board. Looking forward to seeing how you guys flesh things out next month and look forward to seeing if you guys come up with a bill. Are there any questions from the committee on... Thank you. On this role, Behavioral Health Policy Board, I don't see any. Okay, we'll move on to the next one. The last but not least, Washoe Regional Behavioral Health Policy Board, Ms. Edwards, I believe in Carson City, to present on the board I serve on. So I'm looking forward to for everyone else to hear what we're trying to do with that board. Please introduce yourself and proceed when you're ready.
Good morning, Madam Chair, members of the committee, staff, and guests. I am Dorothy Edwards, the Washoe Regional Behavioral Health Coordinator. I also submitted a summary that provides a bit more explanation of what I'll touch on this morning. I ask your forgiveness. I'm going to read from notes to stay on time and on task. The responsibilities, as you heard, along with the criteria for board composition, are outlined in NRS 433. But you can see we have a strong composition of subject matter experts. The board is currently chaired by former Senator Julia Ratty in her current role as Director of Programs and Projects for the Health District. The vice chair is Steve Schell, who serves as the Vice President of Behavioral Health at Renown Health. And then we're honored to have the fabulous Assemblywoman Sarah Peters as our legislator. That earns me points, right, Assemblywoman? Each biennium, the board works on establishing priorities and opportunities for support within the behavioral health community through review and analysis of behavioral health data, collaboration and outreach with our state and county behavioral health partners, locals, and a review of existing behavioral health legislation. Board members select subjects or areas that might require policy development, revision, enhancement in the field of behavioral health. You can find a much more detailed breakout of data and policy development in the annual report and the behavioral health profile that we as coordinators do each year. Developing a crisis response system has been Washoe's largest area of attention, frankly, for the last several years. We know that people are experiencing challenges to mental and behavioral health on a daily basis. Additionally, COVID-19 has impacted not only the economic and physical well-being of communities, but the mental health of individuals and families across the country. A robust crisis response system ensures that every person in crisis receives the right help at the right time in the right place. Far too often, and probably repeating what you know, individuals experiencing a behavioral health crisis are transported to jail, in part, and unfortunately, due to the likelihood they'll receive treatment referral more readily there than other methods, or sent to an emergency room, which is also inappropriate and creates an ethical and fiscal issue. So during this past biennium, the Washoe County Health District contracted with social entrepreneurs to support the implementation of a behavioral health crisis response system in Washoe County region, which includes the city of Reno, Sparks, and Washoe County. This regional planning project is designing a continuum of services to stabilize and engage anyone experiencing a behavioral health emergency and link them with appropriate interventions to address the crisis. This has been an amazing collaboration because what you don't see too often is what we are now experiencing. Collaboration and leadership at the table from city and county, law enforcement, emergency responders, and other behavioral health professionals. We have subject matter experts, technical advisory committees, all following SAMHSA's guideline for behavioral health crisis. So just to remind you before I move on, the three prongs or legs of a crisis now, well, can't say crisis now anymore, that's copyrighted, I think, but the crisis response system is first, someone to talk to, and that's represented by our Crisis Support Services call center, a call line. Also, of course, enhanced now by our 988 call center ability. Then someone to respond. So this will be a mobile response team composed of a peer and a mental health clinician. This does not take the place of the higher level MOST team, which is comprised of law enforcement and a higher level clinician when law enforcement is necessary, but most of the time we're finding that that would not be the case. And then thirdly, it's someplace to go. And that is the Crisis Stabilization Center, and this is what Washoe County we're currently working to roll out. I couldn't give you a date. We spent last year on our implementation plan, and now that we've perhaps identified a vendor and a location. We're hoping this next year or so to actually roll out an opening. I'll keep you informed. So another subject that we considered a priority over the last couple of years was the equitable focus on substance use disorder. We actually were able to address that in our last legislative session BDR, which was Senate Bill 69, and that actually addressed several areas around substance misuse, and I have provided some bullets there I won't read to you, but priorities for the board. This outlines some of the additional areas the board has identified this year. So what we've done is we have had discussions and research around all these areas as we identified where the board could lift up and or support policy development, all in compliance with the criteria outlined in NRS 433. Behavioral health response before, during, and after a crisis. If we learned anything from the public health crisis, it's that we need a more robust plan and trained staff who can cope with the sometimes overwhelming behavioral health consequences of an emergent event. And you'll see here the strategy for success. I was able to rewrite a draft of an emergency behavioral health plan as an annex to Washoe County's emergency plan. We're hoping to get with the state and our regional partners and do a tabletop exercise soon. We also host the ambassadors, and thank you to the state for helping with that. That's a group of paraprofessionals who have reached out to every individual who has agreed that has tested positive for COVID-19, provided daily a list by the health district, and to offer help and support. I should have brought the data. I did not. I can provide that. But we have had thousands of contacts, and it has just been phenomenal what these people have been able to help these individuals just get resources. Sometimes they don't need anything, but sometimes they need someone to talk to. I was contacted last week to see if we could provide some resources to those, fortunately, small handful of individuals that have tested positive with monkeypox, and we have been able to provide some assistance there as well. Diversity and inclusion. The behavioral health needs of minority communities have been historically and disproportionately underrepresented. The Washoe Board seeks to identify and promote the effective retention strategies for prevention, treatment, and recovery support providers and providers who are or who will serve members of all minority communities. The mental and behavioral health needs of children. So while our crisis response implementation plan is for adults 18 and older, the Washoe Board realizes the need for similar services for our youth, realizing that children cannot be treated in behavioral health crisis in the same way as adults will. And so we are supporting our partners that are working on advancements and participate. I personally participate in as many of those groups as I can, bringing forward the continued concepts and plans for children's behavioral health need to our county leadership. Behavioral health workforce, I'll just mention that briefly in a minute. And then, of course, housing and behavioral health. Our crisis response center is not going to cure homelessness, but we know that chronically homeless individuals suffer from mental illness and substance use disorders often, and so adequate housing is seen as a critical foundation to providing successful treatment. So lastly, our legislative priorities over the last biennium. I mentioned the 2021 BDR, which was born as SB 69. That was passed. And then this year, so give me some grace. Just last week, our board voted on our concept. And you might be surprised because we have been all about crisis response in our county and around our board. So you might be surprised to hear that our BDR is also focusing on a component of workforce development. It was a unanimous vote by our board, But really, the reality is we can have a beautiful crisis center, a nice building with all the bells and whistles. We can have policies in place. We can have a robust plan. But if we don't have staff to address a behavioral health crisis before, during, and after, it's all for naught, waste of money, time. And so we realize that we have to also forge ahead with pushing workforce development. Now, again, our concept is, I have a couple sentences to describe it. We're still fleshing it out. We're anxious to, of course, work with our rural regional board and then any other supporters, frankly, of legislation that has to do with workforce development. But our current concept will focus on increasing and retaining our behavioral health workforce through more graduate medical education slots such as psychiatry, APRNs. We're looking at advancement in the other licensure areas as well. We're looking into the need for more support for organizations and individuals who supervise residents and interns, and Ms. Haskin gave us a great overview of that need. So as I said, we're just now exploring. We've got meetings scheduled next week. We're working with hospitals, UNR, and some of our other partners to sort of really fully flesh out the concept so that we can support it to LCB by our deadline. So that gives you an overview of what Washoe County is busy doing. I invite you to attend the meetings if you'd like, and certainly reach out to me if you have any further questions. Thank you, Chair.
Thank you so much, Ms. Edwards. We really appreciate your time here today. Is there any questions from the committee? Are there questions? I'm not seeing any here. I can't see our folks online or in person, so please pop on if you have questions. All right. Well, thank you so much. I just want to go back around. Are there any questions, follow-up questions for some of our other speakers from the regions? Well, thank you all for sticking around. Appreciate your time today. Looking forward to seeing these BDRs get fleshed out and working together on them in this next coming legislative session. I'm going to go ahead and close out that agenda item and move on to agenda item 6. An overview of the Patient Protection Commission, Department of Health and Human Services, and its work during the 2021-2022 legislative interim. I believe that the PPC, another acronym, Patient Protection Commission, met just recently to discuss and vote on their proposed BDRs. So I'm looking forward to hearing what came from that meeting. Please, Ms. Southard, go ahead, introduce yourself when you're ready, and proceed.
Thank you, Madam Chair and members of the committee. My name is Melinda Southard, and I'm the Executive Director for the Nevada Patient Protection Commission. Today, I will be giving you an overview of the Patient Protection Commission, or PPC, as well as the priority focus of the PPC over the past year, the healthcare cost growth benchmark, and then finally, a brief overview of the 3 bill draft requests, or BDRs, the Commission will put forward to the Legislative Council Bureau. We will start with an introduction of the PPC. First, just a little background. The PPC was initially created by SB 544 in 2019. This bill was sponsored by the governor and approved by the Nevada State Legislature and was codified to NRS Chapter 439. Then in 2021, a few modifications to the PPC were approved with the passage of AB 348. These included the Commission's membership, additional responsibilities and topics for review assigned to the PPC, movement of the PPC from the Governor's Office to the Department of Health and Human Services, required the PPC to adopt bylaws, and designated the PPC as the sole state agency responsible for managing Nevada's participation in the Peterson-Milbank Program for Sustainable Healthcare Costs. And we'll talk a little bit more about that piece later. The current makeup of the PPC is as follows. As you can see, we have a wide variety of organizations, patient advocates, and viewpoints. And also, we do have one current vacancy on the PPC awaiting appointment from the governor. Dr. Mark DeCerbo was just appointed to the PPC as recently as yesterday and will fill the PPC designated membership role for a pharmacist at a pharmacy not affiliated with any chain of pharmacies or a person who has expertise and experience in advocating on behalf of patients. The one remaining vacancy is the designated voting member for a representative of the general public. We also have 4 ex officio non-voting members of the Commission serving in an advisory capacity to the Commission. I see the PPC mission, vision, and values really summed up quite nicely in this quote from the governor, in that the PPC is designated to provide a forum for all stakeholders to come to the table and work together on the critical task of improving healthcare access and affordability in Nevada. The recurring goal the PPC wholeheartedly agrees on is doing what's truly best for the patient. I see this reflected in their work and recommendations in this short while I've been with the PPC since April of this year. As codified in NRS, the PPC is charged with systematically reviewing issues related to the healthcare needs of residents of Nevada and the quality, accessibility, and affordability of healthcare, including prescription drugs. Most notably, for the primary focus of the PPC during the interim, this review includes examining the cost of healthcare and the primary factors impacting those costs. Now we will focus on some of the key activities of the PPC over the 2021-2022 interim. A few highlights of the activities include the development and adoption of the bylaws, as was regulated or required by the passage of AB 348, as well as approval of a conflict of interest form for all voting members to complete. On December 29, 2021, Executive Order 2021-29 was signed regarding the Nevada Healthcare Cost Growth Benchmark. This executive order was in conjunction with Nevada's acceptance into the Peterson-Milbank Program for Sustainable Healthcare Costs back on March 1st of 2021. The PPC did not meet from June through September due to membership constraints. Therefore, after the executive order was signed in December, the reconstituted PPC revisited this topic. Nevada was selected as one of only 5 other states to participate in this program from Peterson-Milbank, and therefore authorized to receive critical technical assistance from the Milbank Memorial Fund and Bennett Health as the PPC worked to advance the healthcare affordability discussion in Nevada to set and implement a healthcare cost growth benchmark through the authority provided in this executive order. The PPC also created a Stakeholder Advisory Subcommittee, initially developed in 2021 to advise the PPC on all matters relating to the Peterson-Milbank Program for Sustainable Healthcare Costs. Since its inception, the subcommittee had 21 members, all appointed by the PPC, and has truly served its purpose over the past 12 months in reviewing strategies associated with the healthcare cost growth benchmark. Yesterday, the PPC voted to continue to engage stakeholders by way of an email distribution model to solicit feedback on all matters related to the Peterson-Milbank Program for Sustainable Healthcare Costs and the Healthcare Cost Growth Benchmark, while additionally deciding to pause on formal meetings of the subcommittee until a later date. The stakeholder email distribution will be all-encompassing in that it will include the 21-member Stakeholder Advisory Subcommittee, as was originally approved in 2021, with the addition of the newly suggested members as noted during both the July and August Commission meetings. The stakeholders will continually be asked to give input either verbally or in writing during the PPC public meetings to ensure active continued communication and engagement between stakeholders and the Commission. The work associated with the Peterson-Milbank Program for Sustainable Healthcare Costs has been the primary focus of the PPC over the interim. The technical assistance awarded to Nevada and associated with this program will currently expire after December 31st, 2022. However, the work will continue. The cost growth benchmark is one of the first steps in helping to make healthcare more affordable and transparent in Nevada. To support this statewide effort with the Peterson-Milbank Program, Governor Sisolak had requested assistance of the PPC to provide recommendations specifically to develop a statewide healthcare cost growth benchmark, calculate and analyze statewide healthcare cost growth, and to analyze the drivers of healthcare cost growth. Per this request, the PPC has been hard at work with the Peterson-Milbank and Bennett Health to provide these 3 recommendations to the governor. So, what is a healthcare cost growth benchmark? So the official definition is that it is an annual rate of growth benchmark for healthcare costs in a given state. I also provided some national statistics here so you can see between 2015 and 2019, the average per capita healthcare cost growth was 4.1%. For those same years, the per capita GDP, or measure of a state's business growth, was only 3.5%, and the average hourly wage growth was only 2.6%. So between 2015 and 2019, healthcare expenditures grew faster than businesses were growing and faster than wages were growing. Some key points to keep in mind about a healthcare cost growth benchmark are setting a public benchmark for a healthcare spending growth alone will not slow the rate of growth. A cost growth benchmark serves as an anchor, establishing an expectation that can serve as the basis for transparency at the state, insurer, and provider levels. The cost growth benchmark is a support strategy to help ensure costs don't rise faster than the economy, state revenues, or wages. To be effective, it must be complemented by supporting strategies, and a cost growth benchmark is not a price control. Here, I'd like to share with you the visual model associated with explaining what a cost growth benchmark is, and the alignment with the focus and activities of the PPC over the interim. First, we start with measuring. We have to first measure performance relative to the anchor or the benchmark. Next, we analyze. Okay, so we see that our performance either falls above or below the benchmark for a given year. Now let's do a deeper dive into that data to find out why. What specific factors relative to healthcare costs are driving those costs higher or lower in a given category? After the analysis phase is complete, we then report on the findings. Here's what we found out as to what specific factors are driving up healthcare costs in the state. It is also important to note here that the findings will be shared with the healthcare and insurer industry prior to being publicly released, so the industry can additionally validate the findings for accuracy and be well poised for public release of the report. After reporting out on the analysis, we would then have conversations within healthcare industry experts in Nevada to identify those opportunities and potential strategies to help slow healthcare cost growth in the state in a collaborative and effective way. Lastly, of course, we work together with our partners to implement those cost growth strategies. A few points to highlight around Executive Order number 2021-29 for the Nevada Healthcare Cost Growth Benchmark are that this executive order established the healthcare cost growth benchmark for years 2022 through 2026, and this set a benchmark of 3.19% cost growth for year 2022 when compared to prior year's spend. The intent, of course, is to help curb those climbing healthcare costs. Because this work has been the primary focus of the PPC over the interim, I'd like to further highlight some recent PPC activities with regard to the benchmark. The PPC had previously requested analysis of both state Medicaid and the Public Employees Benefits Program, or PEB, healthcare spending data, and PEB was being used as a proxy for the commercial market. This was for years 2016 through 2020. This data was presented at the monthly PPC meeting on April 20th, which is archived on the PPC website if you're interested in viewing. The Cost Growth Benchmark Program will assess healthcare cost growth for all Nevada residents with commercial, both insured and self-insured, Medicaid and Medicare coverage, or who receive health care through the Veterans Health Administration and the state correctional system. Healthcare cost growth at the state level is measured using total healthcare expenditures, which includes claims spending, non-claims-based spending, consumer cost sharing, and insurer administrative costs. It is really meant to be that all-inclusive look at healthcare expenditures. And finally, I would like to present to you a brief overview of the final 3 PPC bill draft request concepts for the 2023 legislative session. First, just some brief background. NRS 218D.213 authorizes the PPC to request the drafting of not more than 3 legislative measures which relate to matters within the scope of the Commission. Since March, the PPC has been having a more focused discussion on potential BDR topics for the 2023 session. A total of 16 topics were initially brought forward for consideration, which truly is an impressive number for such a young commission. With one topic being withdrawn, a total of 15 topics have been up for consideration for a few months now. After much deliberation and discussion, the PPC has reached consensus on its final 3 BDRs in support of the charge of the PPC. While I will be providing you a brief overview of these topics today, I look forward to a much greater in-depth analysis and detailed description to present to you on these topics officially during the 2023 session. Today, I will only be providing a very brief statement of each BDR. The first PPC BDR is to codify the Nevada Healthcare Cost Growth Benchmark Program as set forth in Executive Order 2021-29 and to include a requirement to measure and report on primary care spending. The second PPC BDR is to mandate that all providers of healthcare and custodians of healthcare records implement an interoperable electronic healthcare record system, expand immunity for provider compliance with providing and receiving electronic medical records, and revision of NRS 439.584 with relation to health information exchange and other areas identified. The third and final PPC BDR is to address the rising costs created by healthcare market consolidation by prohibiting hospitals and possibly some other facilities, such as freestanding emergency rooms, from hiring physicians. Revise these exemptions now in law to ensure that only public hospitals and academic institutions are exempted. With that, I also wanted to present for your consideration 2 topics that were not chosen for final bill draft requests from the PPC, but have the full support and recommendation from the PPC as equally valuable topics. One being to request a study to be completed by an experienced vendor to determine different strategies and design decisions for a health insurance program for infants, children, and young adults up to age 26 who are ineligible for full Medicaid coverage under federal law due to their current residency or immigration status, to outline coverage options that are primarily state-funded, and to conduct a return on investment study of at least 2 options selected by the PPC to inform future proposals and budget requests as they relate to addressing the growth of healthcare costs related to the health status of this population. The PPC must procure a vendor to complete that analysis at no greater than $200,000. With this item, I would like to note that the PPC did vote yesterday to add this topic as a budgetary consideration for the Department of Health and Human Services Patient Protection Commission budget proposal for the next biennium as an alternative approach to a BDR. However, the PPC would also like to put this item forward in a letter to the legislature, noting full recommendation and support of the PPC for this topic being put forward during the 2023 session. The other topic being recommended by the PPC for consideration is to create a prescription drug affordability board and to expand on NRS 439B.630 to set allowable rates for certain high-cost drugs identified by the board. Additionally, of note for this item, the PPC also voted yesterday to include this topic in a letter to the legislature noting full recommendation and support of the PPC for this topic being put forward during the 2023 session. I will be drafting the document and posting for consideration, approval, and signature of the PPC anticipated during the September meeting. That is all for my presentation today, and I thank the committee for inviting me here for this informational item. I'd now like to welcome any questions at this time. Thank you, Chair.
Thank you so much for the presentation. I'm really excited about these options you guys have come up with, and looking forward to hearing more about how they flesh out. Are there any questions from the committee on these BDR recommendations or adopted BDR recommendations from the PPC?
Madam Chair?
I'm seeing, yes, please go ahead.
So thank you. Thank you, Madam Chair, for the question, and thank you for your presentation. Definitely, you have perked my interest in your potential 3 BDRs, and I definitely want to hear more about them because of the potential positive but also significantly negative impact they may bring forward. Just listening to the concept, especially on the electronic medical records and communications. If that BDR, as a primary care provider, we were mandated that we go to electronic medical records, but we weren't mandated that to communicate with each other, and so everybody started their own medical records. And then it really has been a problem. Unfortunately, the cost of doing all of that to the providers has been tremendous, and I'm concerned that although it may be well-intended, it may have significant negative impacts. So as that particular one moves forward, I'd love to have some more information on that as you and your board meet. I appreciate what you're trying to do, but again, sometimes the pathway to where is paved by good intentions, and so I have big concerns about that. So would appreciate some follow-up on that as it moves forward. I am also somewhat concerned about your first and third BDR drafts, and would love to be involved as you meet. And you're meeting again in September to kind of sort some of this out. But those are the three potential bill drafts. You might throw others in, or those are what you're going with?
Melinda Southard for the record. So these three BDRs that I presented today will be the three BDRs that the commission is decided to put forward to the legislature.
Good. And so you're going to do that. You're going to send that forward, but obviously the language hasn't been developed at this point in time. These are conceptual. So if, to whatever extent possible, before they are submitted as final draft to the legislature, I'd love to be able to support them, but it helps if I know what's in them beforehand, so that I'm not testifying against them when I'm in the Senate. So I'd appreciate your reaching out. Thank you.
Melinda Southard for the record. Thank you very much, Senator Titus, and absolutely willing to work with you and communicate with you as these move forward. Thank you.
Assemblywoman for just a little longer, just a little bit. Thank you, Melinda. And I think this is a kind of an important point to make, that these BDR recs are conceptual at this point, and that they are getting fleshed out through the research and development process up until they are introduced in session. And then we still have the entire legislative session through stakeholders working together prior to and beyond the initial hearings and voting on these bills in both houses. So the process is not complete. It is really just the beginning of a vast process through getting these BDRs into law. Anyways, thank you for your presentation. I don't see any additional comments coming up. We look forward to seeing these flesh out and receiving some of those letters you mentioned. Thank you so much for being here today, Ms. Southard.
Thank you.
I'm going to go ahead and close out the last of our presentations there, and we're going to hold on just a second. Okay, we're going to take a quick bio break before we jump into work session, like 5-minute recess. Do I need a motion on this, or can I just declare 5-minute recess? We'll be back just real quick after a bio break. I'm going to ask our virtual members and Carson City members to please take your seat. We're going to get started here in a minute. All right, we're going to get started here. If folks can turn their cameras on and get back in their seats, I want to call us back to our convening and open up our agenda item 7, which is our work session. I hope everyone has their work session documents in front of you. We've had some suggestions on language changes that we're going to go through as we go. I'm going to ask, let's see. I'm going to go back to my script. Yes.
Madam Chair, on the work session, as I understand it, they're all dealing with BDRs and then regulations. Is that right? Or just BDRs?
All of these are BDR work session recommendations. And
So
I think we have a couple of letters, but those are separate from the BDR recs.
If the BDR recommendations, knowing that they're BDRs, do we need to be too fussy about what the verbiage is because they're BDRs and they're going to be debated and discussed and dissected during the session? So are we going to spend a lot of time on it or just say, isn't it wonderful we have BDRs and we're going to send them on?
Doc Hardy's ready for his last committee meeting to be done. So in most cases, yes, I would say the same thing, and I've asked staff for their input on the importance of some of these language changes that have been suggested. There are a couple where, as we saw from Interim Judiciary Committee, they adopted a measure that was included in one of ours. So we'll remove that piece before we adopt our BDR rec. There's a little bit of a language change that creates a pretty significant change with the certified versus leaving out certified in the item K, community health workers. I'm looking at that as if we don't include certified in this BDR draft language, we may be looking at some significant fiscal notes on it. So we'll change that. And then We happen to have one extra BDR, and so I was going to ask to split one of these out. So we've just got a couple of things to go over, not big modifications to language at all, but just some things to clean these up before we hand them over to the drafting process.
All right, appreciate it. Thank you.
Okay. So moving on, we have the work session. Members, the work session document is posted on the committee's meeting page. There are also hard copies over here if you'd like, on the tables in the committee rooms if you'd like to grab one. It contains a list of proposed recommendations related to child welfare, the COVID-19 health crisis interim study, and multiple other matters in the purview of our committee. I just want to take a moment to thank everybody who has been a part of this interim committee, who has brought recommendations to the committee in your presentations, and who has worked with us on the substantial issues in our state, including significant discussion around behavioral health, and the needs for both our adult communities and our children's communities. I'm going to ask Mr. Ashton to walk us through the document, and we will go one by one through each of these, and I will ask for motions as we go. Please, Mr. Ashton, proceed.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst of the LCB Research Division. Just my usual reminder, as nonpartisan staff, I can neither advocate nor oppose any measures that you will consider today. The Chair and LCB staff of the Joint Interim Standing Committee on Health and Human Services, HHS, prepared this work session document to assist the committee in determining which legislative measures it may request for the 2023 legislative session. Committee staff compiled and organized the proposals so that committee members may review them and decide whether they want to accept, reject, modify, or take no action on the recommendations. The document groups the proposals by topic, and they are not preferentially ordered. The HHS committee may request up to 15 bill draft requests or BDRs that relate to matters within the scope of the committee. The committee may choose to recommend any of the following actions: draft legislation to amend NRS, draft a resolution, draft a letter, or include a policy statement of support in the committee's final report. It should also be noted that any potential recommendations listed may or may not have a fiscal impact, and any potential fiscal impacts have not been determined by staff at this time. Madam Chair, may I proceed with recommendation A?
Please go ahead.
Thank you. We will begin with recommendation A regarding commercially sexually exploited children, or CSEC, which you can find on page 2 of the work session document. This recommendation was proposed by Bridget Duffy, Chief Deputy District Attorney at the Clark County Office of the District Attorney during the April 21st, 2022 HHS meeting. The recommendation is to request a BDR to, number 1, require training for teachers, administrators, and individuals working in the child welfare and juvenile justice systems to identify and assist children who are commercially sexually exploited or are at risk of being commercially sexually exploited. Number 2, require all child welfare and juvenile justice agencies to use evidence-based screening methods for children and their care. Number 3, revise Chapter 432C of NRS to allow the formation of multidisciplinary review teams for CSEC. An agency of a local government entity may appoint and organize one or more multidisciplinary teams to review the cases of children who are victims or survivors of sex trafficking and exploitation. And for item 3, see also the suggested language in attachment A3 of the work session document. Item 4, establish a statewide executive committee within the DCFS DHHS to evaluate the cases of children who are commercially sexually exploited. And number 5, enhance and streamline stronger safe harbor statutes for CSEC by adding crimes of trespass, minor and gaming establishment, obstructing an officer, and possession of false identification. Stakeholders indicated these misdemeanor offenses are more likely to bring victims of commercial sexual exploitation to the attention of law enforcement. Chair Peters and committee members, I want to note that last Friday, the Joint Interim Standing Committee on Judiciary voted to draft legislation that is similar in its request to item 2 of the CSEC recommendation, which is the requirement to use CSEC screening methods. If you want to move forward with this BDR recommendation, you may want to exclude item 2, since it will be drafted and introduced as a separate BDR for the upcoming 2023 legislative session. Thereby, you would avoid the duplication of efforts. Chair Peters.
Thank you so much, Patrick. Mr. Ashton. I would like to ask for questions, but I want to just reiterate that this is not the forum for debate on these bills. These are not bills. These are BDR ideas. So if you have questions related to the ideas, we do have experts in the room. Are there any questions from the committee?
The only
Seeing
question
none,
I have, Madam Chair, is can I say I move that we approve it without number 2?
Thank you so much, Senator. I have a motion to approve the recommendation with the removal of item number 2 on our recommendation list. Is there a second? Second from Vice Chair Doñate. Any discussion on the motion before we vote? Seeing none, all in favor, please say aye or raise your hand. Aye. Any opposed? Say nay. I don't know if I have a delay in Carson City or Assemblywoman Titus. Would you just confirm your vote?
Yeah, I am. I tried to grab my microphone before when there was a discussion, so I'm sorry that I didn't get that
sorry.
in. I'm going to support it, but I want to do with the caveat that the ultimate final BDR I may not be able to support until I see it. So I'm going to support it absolutely to get it out of this work session. Thank you.
Well, I appreciate that. As always, this is not a commitment to a vote during session. I appreciate your discretion in that, but I also appreciate you helping us move this forward. With that, the motion carries with those in attendance.
Madam Chair,
Yes.
I'm not going to vote for any of these during session.
Well, I have a statement about that after we get done with the work session. We will make note of your support of the work session document in the session. I'm just kidding. We won't hold you to that. All right, I think we can, if that's all, I just want to check in and make sure we followed process, everything's clear, we're good to go. We're going to move on to work session item B.
Thank you, Madam Chair. For the record, Patrick Ashton. Next is recommendation B on homeless youth and young adults under 25 years of age who are experiencing homelessness, which you can also find on pages 2 and 3 on the work session document. And this recommendation was developed by Chair Peters in consultation with committee staff in response to testimony provided by Mr. Macaluso, Chief Executive Officer Eddie House, at the April 21st HHS meeting. The recommendation is to request a BDR to number 1, ease requirements for homeless youth and young adults under 25 years of age who are experiencing homelessness to obtain essential documents as follows. Item 1A, revised Chapter 440 of NRS to provide a minimum of 30 days during the application process for a certified copy of a birth certificate to show proof of all necessary documents required for birth certificates of homeless persons, including without limitation a homeless child or young adult under 25 years of age who's experiencing homelessness. Item B, remove the requirement to show proof of a social security number of a homeless youth or young adult under 25 years of age who's experiencing homelessness when applying for a state identification card. Item C, authorize school identification cards as an alternative method to show proof of identity when applying for a state identification card with certain conditions. Item D, waive any costs associated with receiving a state identification card for a homeless youth or young adult under 25 years of age who's experiencing homelessness. And E, authorize DWSS, DHHS to assist with the issuance of a state identification card. The division shall collaborate with the DMV to facilitate this additional outreach service. Now moving to item 2 of this BDR recommendation, require a county with a population of 100,000 or more residents to develop a strategic plan to address homelessness by the respective governing bodies of the county and the cities within the county. The strategic plan shall contain the sub-items A through E as outlined in the work session document on page 3. Each such county shall develop a strategic plan on homelessness and present it to the Joint Interim Standing Committee on Health and Human Services next legislative interim. Madam Chair.
Thank you so much. Are there any questions from the committee regarding this recommendation? Seeing none. I have a motion from Senator Hardy. Is there a second from Vice Chair Doniate? Any discussion on the motion before we vote? I'm going to give it a second in case Dr. Titus wants to pop on, just because I think there's kind of a delay.
I saw Senator Hardy. Maybe he wants to go first.
Senator Hardy.
I think I move to approve this as a BDR. In as much as it's committee BDR, I recognize that we aren't held to what is actually going to be in the verbiage, nor are we held to that we're actually going to support it during the next legislative session. But this will obviously, my motion will include it to be a BDR, which will be discussed, debated, and dissected during the session. Thank you.
Thank you for that. Any other discussion? Seeing none, all those in favor, please signify by saying aye or raising your hand.
Aye.
Any opposed? Motion passes with those in attendance. We can go ahead and move on to agenda item, this BDR item C.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. Now we are moving to item C, behavioral health care, on pages 4 and 5 of the work session document. This recommendation was developed by Chair Peters in consultation with committee and DHHS staff in response to various testimony at the March 24th HHS meeting. There are 2 items under this recommendation for BDR. The first item relates to regulatory clinical oversight of behavioral health care, specifically, number 1, require DCFS and DPBH DHHS to each formulate and operate a comprehensive statement for behavioral health clinical standards of care for children and adults. Number 2, require each division to coordinate the efforts to carry out its state plan and coordinate all state and federal financial support for behavioral health services in Nevada. Number 3, require a behavioral health care provider to consult and advise with either division in the planning of projects and all applications for grants from within the state which are concerned with programs for behavioral health treatment. Either division shall review the applications and advise the applicants concerning the applications. Item 4, require each division to certify or deny the certification of behavioral health care programs based on the standards established by either DCFS, if relating to programs treating children, or the State Board of Health, if relating to programs for adults. Any behavioral health care providers, facilities, or programs that are not certified shall be ineligible to receive state and federal money for programs for behavioral health treatment. And number 5, require DCFS and the State Board of Health to adopt regulations that prescribe the clinical care standards for behavioral health treatment providers for children and adults, respectively. The second item under this BDR recommendation relates to cost savings reinvestments in children's behavioral health systems of care. The BDR would define the children's behavioral health system of care as outlined in sub-items A and B of item 6. Item 7, it would require the Commission on Behavioral Health, DPBH, DHHS, to track the spending of federal funding in the children's behavioral health systems of care to account for costs avoided across the child serving systems within DHHS. Item 8, require DHHS to establish an evidence-based methodology to quantify averted expenses. Item 9, establish authority within the Commission on Behavioral Health to provide oversight for the use of the funding for the purposes of reinvesting those funds in the children's behavioral health system of care in accordance with best practices. And number 10, require the Commission on Behavioral Health to prepare and submit a report for the Governor, the Director of DHHS, and the Director of the LCB by August 1st of every even-numbered year, preceding the next regular legislative session. And this report shall include the projected amount of costs avoided by the state for the next biennium, and recommendations to the Senate Committee on Finance and the Assembly Committee on Ways and Means for the reinvestment of those cost savings. Chair Peters, Dr. Woodard, and Dr. Pitlock are available for questions, Madam Chair.
Thank you so much, Mr. Ashton. Are there any questions from the committee? Seeing none, I would entertain a motion to approve the recommendation C. I have a motion from Vice Chair Doniate. I have a second from Assemblywoman Gorlow. Is there any discussion on the motion? Seeing none, all those in favor say aye or raise your hand. Aye. Any opposed? Nay. Seeing none, the motion carries with those in attendance. Thank you so much. This is a big lift, but I'm very excited for the future of Nevada's behavioral health systems. Mr. Ashton, please proceed with BDR recommendation D.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. Now we are moving to item D, Qualified Residential Treatment Programs, or QRTP, on page 5 of the work session document. And this recommendation was proposed by Joanna Jacob, Government Affairs Manager of Clark County. This recommendation also relates to testimony provided by Dr. Rice, Deputy Administrator of Quality and Oversight, DCFS and DHHS, on the Family First Prevention Services Act at the April 21st HHS meeting. The recommendation is to request a BDR to revise the definition of childcare institution and NRS 432A-0245 to include QRTPs pursuant to the Family First Prevention Services Act. The QRTPs should be able to provide services for up to 25 children, different from a childcare institution, which provides services to 16 or more children. We have Joanna Jacob present, as well as several representatives from DHHS to answer questions. Madam Chair.
Thank you so much, Mr. Ashton. Are there any questions from the committee? Seeing none, I would entertain a motion to approve the recommendation. I have a motion from Vice Chair Doniate. Do I have a second? From Assemblywoman Gorlow. Any discussion on the motion before we vote? All those in favor, please signify by saying aye or raising your hand. Aye. Any opposed? Nay. The motion passes with those in attendance. Thank you so much. Please go ahead to agenda item 8.
For the record, Patrick Ashton, Committee Policy Analyst. Recommendation E is on fetal alcohol spectrum disorders, or FASD, which you can find on page 5 and 6 of the work session document. This recommendation was proposed by the Grant a Gift Autism Foundation, Children's Advocacy Alliance, and the Nevada chapter of the American Academy of Pediatrics during the solicitation of recommendations period. The recommendation is to request a BDR to add fetal alcohol spectrum disorder to the definition of developmental disability set forth in NRS 435-007 and revise NRS 442-003 to read fetal alcohol spectrum disorder instead of fetal alcohol syndrome and make corresponding changes throughout NRS. Committee members, we have several representatives present from the entities that made this recommendation, as well as DHHS subject matter experts. The work session document also contains a brief intent of this recommendation. Madam Chair.
Thank you, Mr. Ashton. Are there any questions on this item? Sorry, I saw Dr. Titus was reaching forward for her mic. Seeing none, I would entertain a motion. Vice Chair Doniate, thank you. A second from Assemblywoman Gorlow, thank you. Is there any discussion on the motion before we vote? Seeing none, all those in favor, please signify by saying aye or raising your hand. Aye. Aye. Any opposed? Nay. Motion passes with those in attendance. Thank you so much. We'll go ahead and move on to BDR recommendation F.
For the record, Patrick Ashton, Committee Policy Analyst. Item F is on school-based health centers. On page 6 and 7 of the work session document, you can find this recommendation, which was developed by Chair Peters in consultation with the committee and DHHS staff. The recommendation is to request a BDR to, number 1, require Nevada Medicaid and ENDO, the Nevada Department of Education, to collaborate on a study to review standards of care and evaluate opportunities to reduce the complexity of certification through DPBH for school-based health centers. This includes to evaluate the need for an on-site laboratory, review the requirement for school board approval if the school-based health center is near school and not on school grounds, review Medicaid reimbursement rates, consider opportunities to incentivize school-based health centers, and also then to submit the study's findings and recommendations to the Joint Interim Standing Committee on Health and Human Services by December 31st, 2023. Number 2 requires DHHS to develop a resource office to help providers with the certification, Medicaid enrollment, and billing for school health services and certified school-based health centers, or other alternatives, such as a satellite clinic for those currently able to bill Medicaid through physician-provider types. And number 3, ensure school-based health centers are enrolled in Medicaid managed care provider networks by requiring Medicaid managed care organizations to contract with all school-based health centers by designating the school-based health clinics as essential community providers for the Medicaid managed care programs. Chair Peters and committee members, we have several subject matter experts from DHHS present in case you have any questions. Madam Chair.
Thank you so much, Mr. Ashton. Are there any questions from the committee on this recommendation?
I do have some questions on this one.
Okay, please go ahead.
Thank you. So whoever's here to answer those. So school-based health centers, I take it, already exist, correct?
That is correct.
Okay. Then clarify for me the issue about the requirement for school boards have to authorize these if they're not on school grounds. Is that already existing? Has there been an issue there?
That is a great question. The point of this study is to review the requirement for a school board to approve. How much that is an issue to date is not clear, but it is important to assess that as a potential barrier to access to off-campus school-based health centers, which essentially would be community health centers.
So just thank you for that. So clarification. Have all 17 different county school boards, in any of those, are there regulations? We don't know if there are any regulations that limit them off campus from the school boards? I mean,
Do we have, I'm trying to remember who's on our call. Someone on the line who can speak to the existing regulations?
While you're waiting, Madam Chair, may I say something?
Please go ahead.
Obviously, you have to have all sorts of things that the center has to be able to qualify for Medicaid reimbursement as well as the provider. And so the study, as I see it, is putting together what it would take to have a either on-site or off-site providership and a provider in order to qualify for Medicaid reimbursement, which is problematic. And I'm sure somebody has done it somewhere, but it is something that would be a new creature, as I understand it. You'd have a lot of hoops to jump through, and I think this study is trying to figure out what those hoops are so they could do it. And I don't think that maybe all school boards are going to be able to adjust to it, but I think that's why we study it. Thanks.
Thank you for that. I believe that Ms. Ives with DPBH was on and willing to jump in on this one. Please proceed.
Thank you, Chair. Vicki Ives for the Record Division of Public and Behavioral Health. There is nothing in the certification process with the Division of Public and Behavioral Health that speaks specifically to any regulations related to the school districts. I do know Nevada Department of Education had folks as well that they might want to speak to that piece, but there's nothing intrinsic to the certification process on DBH's side that creates a barrier, nor have we been identified of that specific barrier, but thank you.
Thank you. And I want to be clear on the point of a study, Dr. Titus. We have this ability to pull together school-based health centers. It exists. we don't have very many, and it seems like low-hanging fruit for access to children and their families on creating relationships with primary care providers and with other providers. We have private partners such as Communities in Schools, and I think Family First in Las Vegas does this as well, where they act as kind of care managers and coordinators for kiddos in schools. So we are already trying to piece parts of this together. This bill is really trying to pull everyone into the same room to talk about how does it work on the ground, what works for everybody, and what doesn't, and how can we make sure that we are getting kids the best care that we can where they are, which, because school is mandated in schools.
Absolutely.
Do you have a follow-up?
Right. So I do, and thank you for that. I do appreciate the concept. Just want to make sure that is this really? Do we need a BDR? Do we need a law, a bill to address this? Or is it something we can do outside that scope? Perhaps through the Division of Healthcare. But it sounds like it's kind of forcing folks to communicate with each other. And sometimes that's what our job is, making this thing happen. So I'm supportive of the concept. But the next question I also had was the number 3, which was the ensure that they're enrolled in Medicaid managed care provider networks. Certainly out in the rurals in many areas, our hospitals are fee-for-service and those kind of things, and mandating that they are enrolled in Medicaid will be an interesting concept, especially if they have to in the managed care provider network. So I'll be interested to see how this progresses and how that communication happens and some of the information we get for it. So certainly, I can support the conceptual bill draft.
Thank you for that. You're asking a lot of the questions that I think will have to be fleshed out before session, obviously. So I look forward to continuing to talk about what our different needs are in the communities based on this. All right. With that, I would entertain a motion to approve the recommendation. Vice Chair Doñate. Oh, thank you so much. I've got a second from Senator Hardy. Is there any discussion on the motion before we vote? Seeing none, all those in favor, please signify by saying aye or raising your hand. Aye. Any opposed? Nay. Motion passes with all those in attendance. Thank you so much. We'll go ahead and move into BDR item G.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. Item G you can find on page 7 of the work session document, and it is in regards to licensing of pharmaceutical sales representatives. This recommendation was developed by Chair Peters in consultation with committee staff in response to testimony provided by DHHS staff of the Pharmaceutical Drug Pricing Transparency Program at the July 21st HHS meeting. The recommendation is to request the BDR to require DHHS to license and regulate pharmaceutical sales representatives who are operating within the state. Any fees collected from the licensure of pharmaceutical sales representation shall be accounted for separately in the State General Fund, shall be used only to cover the costs of licensing and regulating pharmaceutical sales representatives, and for the purposes of improving transparency concerning the costs of prescription drugs, and do not revert to the State General Fund at the end of any fiscal year. This BDR would be essentially a redraft from reprint 1 of Senate Bill 201, which did not pass during the 2021 legislative session. Madam Chair.
Thank you, Mr. Ashton. Are there any questions on this recommendation? Seeing none, I would entertain a motion. Motion from Vice Chair Doñate. Do I have a second? From Assemblywoman Gorlow. Is there any discussion on the motion? Seeing none, all those in favor, please signify by saying aye or raising your hand. Aye. Any opposed? Nay. Raise your hand. Is that Titus? I can't. Can you confirm, please, verbally what your
I'm going to. Let me make sure we're on G. Correct.
Correct.
I'm going to be a no. Thank you.
Thank you. Motion passes with one nay from Dr. Titus. We can go ahead and move on to agenda item H. Sorry, agenda item BDR recommendation H.
Thank you, Madam Chair. For the record, Patrick Ashton, Committee Policy Analyst. Item H in the work session document is on page 7 and relates to licensing and regulation of pharmacy benefit managers, or PBM. This recommendation was developed by Chair Peters in consultation with committee staff in response to testimony provided by DHHS staff of the Pharmaceutical Drug Pricing Transparency Program at the July 21st meeting. The recommendation is to request a BDR to require a PBM operating within the state to obtain a license from DHHS. Item 2 would be to prohibit a PBM from using spread pricing and to specify that a PBM shall agree to only enter into contracts with third-party payers that are fully transparent to the contractual parties, including but not limited to the disclosure of all rebates, discounts, product pricing incentives, and fees collected by a PBM. The PBM's only source of income shall be from disclosed administration fees for services. All manufacturer discounts, product pricing incentives, and fees collected by a PBM must be reimbursed to the third-party payer, and rebates must be passed down to patients. Number 3, require PBM to allow a client full audit rights, including but not limited to pharmacy claims, rebates, and similar information needed to assure compliance. Number 4, establish a fiduciary responsibility for a PBM to a third-party payer. The benefit of the payer is the primary and sole interest of the fiduciary, and any conflict with that role must be disclosed and avoided. And number 5, prohibit PBMs, Medicaid managed care plans, Medicare Part D plans, including Medicare Advantage Part D plans and private health insurers, to the extent authorized under federal law, from reimbursing less for prescription drugs because they were purchased under the federal 340B drug pricing program, which is also called discriminatory contracting. See also attachment H5 in the work session document. Committee members, this BDR would be a redraft of SB 392, which did not pass during the 2021 legislative session. The exception is item 5 of these recommendations, and you can find background information as already alluded to in attachment H5 of the work session document. We have Dr. Slamowitz as the DHHS subject matter expert, as well as representatives from the Nevada Primary Care Association to respond to any questions you may have. Madam Chair.
Thank you so much. Are there any questions from committee members on this item?
Madam Chair.
Please go ahead.
Thank you. And thank you for bringing this forward. I think it's something we do need to address. There's many states, or several states, that have actually passed some of these laws, and other states that the laws were presented but didn't pass. And do we have any idea what we're being encouraged to model? California's didn't pass. Arizona passed a program that may or may not work in Nevada. There's some other states that are out there. Are we going to mirror any other states?
I'm going to ask Mr. Eric to please talk about how the bill was initially drafted, since this is pulling in a bill from last session. Please go ahead.
Yeah, Eric Robbins, LCB Legal, for the record. So basically, under current law, pharmacy benefit managers are drafted or are either licensed or certified. I don't remember off the top of my head what the credential is, but they have to be go through some sort of registration process with the Division of Insurance. And so what this bill, what SB 392 did propose to do last session, was to take that out while still leaving all of the provisions that currently apply to PBMs as administrators, and basically reenacting them in a different chapter and having them be licensed by the Department of Health and Human Services rather than the Division of Insurance. And then it added in some of these additional provisions about prohibiting spread pricing, requiring the PBM to allow a client full audit rights, and establishing a fiduciary responsibility Currently, a PBM has a duty of good faith and fair dealing. So it would change that verbiage a little bit, but there's not a model from other states. It's just kind of trying to keep what we have in existing law regarding their licensure as insurance administrators and shifting that process over to DHHS rather than DOI.
Thank you for that.
Are there any other questions from the committee on this item? Seeing none, I would entertain a motion from Vice Chair Doñate and a second from Assemblywoman Gorlo. Any discussion on the motion before we vote? Seeing none, all those in, please go ahead, Senator Hardy.
I'm going to take the privilege of voting no on something, as this may be my last chance. Thank you.
I can appreciate that. All those in favor, please signify by saying aye. Or raising your hand. All those opposed, please.
No.
I have 2 nays. Senator Hardy and Assemblywoman Titus. Motion carries.
I'm going to support this until we see how it's all drafted.
I'm sorry.
So
see, the delay is killing me.
I'm a yes on this one. And again, we'll have to continue the discussion further down the line, but I'll support this today.
Thank you so much. I would like to revise that as all members in attendance support except for Senator Hardy today. The motion passes. We'll go ahead and move on to agenda item BDR recommendation I.
For the record, Patrick Ashton, Committee Policy Analyst. Work session item I relates to Medicaid coverage for integrated care models that combine general medical with behavioral health care services, which you can find on page 8 of the work session document. The recommendation was developed by Chair Peters in consultation with committee staff in response to testimony provided by various stakeholders at the February 17th and May 19th HHS meetings. This recommendation was also recommended by Wilson Case, Government Affairs, representing Shatterproof, and on behalf of the Nevada Collaborative Care Model Coalition. The BDR, the recommendation is to request the drafting of a legislative measure to amend the state plan for Medicaid by adding a coverage requirement for mental behavioral health and substance use services that are delivered through evidence-based integrated behavioral health care models, such as the collaborative care model. And members, we have DHHS representatives and subject matter experts from the entities who submitted this recommendation present to respond to any questions that you may have. Madam Chair.
Thank you, Mr. Ashton. I want to just apologize earlier. I think I called Mr. Robbins Mr. Eric. It's been a long couple of days. I apologize for that. Are there any questions from the committee on this item? Seeing none, I would entertain a motion. Vice Chair Doñate, a second from Assemblywoman Gorlo. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye or raising your hand. Aye. Any opposed? Nay. Motion passes with those in attendance. Thank you so much. We're going to go ahead and move into agenda BDR item J, recommendation J.
For the record, Patrick Ashton, Committee Policy Analyst. Item J is on medication-assisted treatment for substance use disorder, and you can find this recommendation on page 8 and 9 of the work session document. It was developed by Chair Peters in consultation with committee staff in response to testimony provided by various stakeholders at the February 17th HHS meeting. The recommendation is to request a BDR to, number 1, require any healthcare provider who is authorized to make a diagnosis of opioid use disorder to provide information and counseling on evidence-based treatment options, including controlled substances used for medication-assisted treatment of opioid use disorders approved by the FDA, to a patient the provider has diagnosed with an opioid use disorder. Number 2, require the healthcare provider to prescribe an FDA-approved medication for the treatment of an opioid use disorder at the patient's request, as long as such a medication has no contraindications for the patient. If the healthcare provider cannot prescribe such a medication, he or she must refer the patient for treatment to a provider that is authorized to prescribe such a medication. Item 3, require all behavioral health care providers in the state to prioritize substance use disorder treatment funded by federal or state money according to the priority populations of the Federal Substance Abuse Prevention and Treatment Block Grant administered by the Substance Abuse and Mental Health Services Administration. And item 4, require all jails and state prisons to offer medication-assisted treatment for inmates diagnosed with opioid use disorder in the same manner and to the same extent as other forms of health care. Prohibit jails and prisons from discriminating against medication-assisted treatment in favor of other forms of treatment or abstinence without treatment. If a person is incarcerated in a jail or transferred from a jail to a prison and has already received medication-assisted treatment, the jail or prison must facilitate the continuation of this treatment. The jail or prison must also take reasonable measures to facilitate continuation of medication-assisted treatment upon release. Members, we have Dr. Woodard from DHHS present to respond to any questions you may have. Madam Chair.
Thank you so much. It was brought to my attention yesterday that some of this language in item 2 did not get directly at the point and purpose, and Assemblyman Ornlicker has been working to address that language. Would you like to present your suggested revision, Assemblyman Ornlicker?
Yes, thank you. So yeah, we rather than saying a physician has to provide upon the request of the patient, it would, I think, work better to say for patients for whom Medicaid-assisted treatment is indicated, the provider should offer the treatment or refer the patient to another provider who can offer the care. We want to make sure that patients have better access and appropriate access, but mandating a prescriber to offer treatment would be problematic in some ways.
Thank you. That does get to the intent of this BDR recommendation as we worked on it. So I would be happy to well, first take questions. Are there any questions on the BDR recommendation as presented? Assemblywoman Titus?
Thank you. I appreciate the opportunity to have a comment and a question. I have concerns. Thank you first for that clarification on number 2, because I had real concerns that we must do something. This state has been actively and aggressively going at, I feel, opioid addiction for a number of years now, at least since 2015 in my first session. There's been rules, rightfully so. Our opioid addiction and overdose is incredibly high and frequently not addressed. But I think we've done a good job going and recognizing the providers component of that and regulating providers and prescription plans, et cetera. To yet add more regulation when we have seen and had testimony in this very committee that despite all of that, we as providers have done a better job. We are not prescribing the medication as we have in the past. The state was successfully involved in a lawsuit to the drug companies to prevent the drug companies' implications and the providers' implications. We've all stepped up. But yet we're still seeing a dramatic increase of opioid deaths. We all know where the drugs are coming from illegally is the real problem, and we're not really addressing that in any of these BDRs. So I'm just frustrated that this is the opioid BDR that we're coming up with, and I just can't support yet more regulations on healthcare providers when what we have done has been excellent, and it still has not affected the outcomes that I can see. So just a bit frustrated. Certainly appreciate the Dr. Ornlicker's addition and clarification about mandates, and I'm just very concerned. Thank you. I know the intent. I know we still see huge numbers, but I'm not sure this is the solution.
Thank you. Senator Hardy.
I'm going to echo what the other doctors are saying, and then add to that when we require medication-assisted treatment, that includes methadone. And methadone may be more problematic in some cells or some jails or some prisons than it is in others. And sometimes we have what we call a therapeutic discharge when we're dealing with somebody who's using or abusing. And when we start to say you have to do something, then it overrides the medical judgment. And I think that's a dangerous position for us to be in. And certainly for the physician who may find him or herself in a very difficult position to be able to have a defense. So I would be opposed to this as it's written.
Thank you for both of your concerns. I'm going to ask if Dr. Woodard is online, if she can talk a little bit about the intent of this bill, that it's not intended to direct folks who are already providing this kind of opioid treatment service to do more, but it's more intended to address the community understanding of the access to treatment. But Dr. Woodard, if you would please go ahead and explain a little more on the intent.
Thank you, Chair and committee member Stephanie Woodard, Department of Health and Human Services Senior Advisor on Behavioral Health, for the record. Chair, you're absolutely correct, and I would like to just go back to what Assemblyman Orentlicher's comments were. So the intent here is actually very similar to some of the language that was added in AB 474 and the Controlled Substance Abuse Prevention Act. The goal would be to preserve the patient and prescriber relationship. There should never be the mandate in law, in my opinion, to mandate the practice of medicine. So the goal here is to ensure that we have the education for individuals who have been diagnosed with an opioid use disorder on the availability and the effectiveness and efficacy of medications for opioid use disorder. I would agree with Senator Titus's comments, especially around the work that prescribers have done to this point. They have carried a lot of weight when it comes to rectifying some of the overprescribing that we were seeing of prescription opioids in the past. So what we are trying to do here is address the other side of the issue. And we do have, unfortunately, very low rates of medication-assisted treatment being offered to patients. Very rarely are they even aware that they have options for medications available to them. And so the goal really is to ensure that individuals who are receiving that diagnosis are being offered what we would consider the standard of care for the treatment of medication of opioid use disorder.
Thank you, Dr. Woodard. Are there any other questions from the committee?
Madam Chair.
Yes, please go ahead.
If Dr. Woodard could address the issue of methadone in all facilities where a person's confined. When we talk about offering medication-assisted treatment, are we doing methadone in all facilities, or are we capable of doing all that? Do we have not just waivers, but licenses for everyone to be able to do that? Do we have enough physicians who are able to do that? Where are we? And do we have some safety factor in doing that? In the prisons, I'm talking about jails or prisons.
Thank you for the question.
Woodard,
Through you, Chair. Stephanie Woodard, for the record. So currently we do have some jails that are actually offering methadone to individuals who are already on methadone as a maintenance drug. where we also have some jails that may not be offering that same connectivity to treatment, even if the individual has previously been maintained on that medication. And so what we are attempting with the language here is to ensure that there is preservation of access to medication for an individual, especially if they've already been established on that medication. Certainly forcible withdrawal for individuals who are in an incarcerated setting leaves them at an increased risk for experiencing overdose upon discharge, especially if they then have to be restarted on medications that they previously had been on. And that connectivity to care upon discharge is really critical for ensuring that people are reducing risk for the potential for overdose upon reentry back into the community.
Madam Chair, if I may repeat my question. Are all of
Yes,
the
please go
jails
ahead.
and all of the prisons able, capable, and adequately manned in order to be able to do that? Do we have the workforce that can do that? Do we have the safety factor throughout 17 counties that can do that?
So Stephanie Woodard, for the record, we would have to reach out to each of the jails and Department of Corrections and each of their affiliated prisons to determine if they had the capacity. We do know that we have demonstrated capacity in some of the jails across the state. So that would be around looking to see if they had the capacity potentially with community partners to be able to provide methadone. I think part of the issue here also is the language that really just describes making sure that they are able to provide treatment for opioid use disorder in the same manner and to the same extent as other forms of healthcare. So I would ask perhaps if we need some additional clarification on that language, that we would not be providing an undue burden by a mandate that would fall potentially outside of what we would consider the same manner and the same extent of other forms of healthcare.
Thank you, Madam Chair.
Thank you. Mr. Robbins has a comment.
Yes, Eric Robbins for the record. I just wanted to kind of clarify for the purposes of the initial drafting of the bill with the proviso that this could change before that the bill is introduced and certainly after the bill is introduced through the amendment process. But with regard to 1 and 2, the way I read any provider who is authorized to make a diagnosis of opioid use disorder would mean that it would apply to, first of all, the prescribers, so the physicians, physician assistants, and advanced practice registered nurses, and then the mental health providers, the psychologists, MFTs, clinical professional counselors, social workers, and alcohol and drug counselors, and that the prescribers obviously would prescribe if it's appropriate, and that the mental health providers would refer to a prescriber to prescribe if it's appropriate. And I just wanted to make sure that was okay for the purposes of, again, initial drafting, or if there's some other approach that the committee would like us to take on that.
I appreciate the comment and the opportunity for the committee to make the initial decision on who to include in the bill. To me, this list sounds like a great starting point, and I appreciate the point that it can be refined through the drafting process and within the legislative session through amendments. Are there any other comments or questions on the bill BDR recommendation as presented? All right. Yes, please go ahead.
I'll be voting no as a red flag. You know, I probably have talked about substance abuse disorder probably more than anybody else around town, and I believe in treating. I think this has dangerous implications, but we're putting ourselves in impossible positions to do something that we're not able to do. So I think it needs to be more encouraging than mandating on lots of different levels. But I will be voting no as a red flag, if nothing else. I think we need to take a step, and this has to be very much more fully vetted than it has been. Thank you.
Madam Chair,
Yes, please go ahead.
I will just echo Dr. Hardy's statement.
Thank you. We're still on the the questions portion of our voting procedures. So I would go ahead and take a motion with the suggested revision on an item 2 presented by Assemblyman Ornlicker. I have a motion from Vice Chair Doñate. I have a second from Assemblywoman Gorlo. Any other discussion on the motion? Excuse me. I have a question from Mr. Ashton.
For the record, Patrick Ashton, just to clarify item 2 here, would it, the changes that you're requesting is that a healthcare provider should offer information about FDA-approved medication-assisted treatment, but not be required to prescribe it when requested by a patient? Is this the intent?
The intent that I have is for patients whom MAT is indicated, the provider should offer the treatment or refer the patient to another provider who can offer the treatment.
Thank you very much.
I have a motion and a second. We've clarified the intent and language. All those in favor, please signify by saying aye, raising your hand. Aye. All those opposed?
Nay.
Nay.
Thank you. We have 2 nays, Senator Hardy and Assemblywoman Titus. The motion passes. Thank you so much. We'll go ahead and move on to BDR recommendation item K.
For the record, Patrick Ashton, Committee Policy Analyst. Item K is in regards to community health workers on page 9 of the work session document. This recommendation is from Jay Colbert-Klausel, Program Manager of the Nevada Community Health Worker Association, and was provided during the July 21st HHS meeting. The recommendation is to request the BDR to, number 1, revise NRS 4222722 by authorizing DHCFP to promulgate policies regarding who may supervise community health workers who provide services to Medicaid patients in addition to a physician, physician assistant, or advanced practice registered nurse. The intent is to ensure that DHCFP has the authority to expand the field of settings where community health workers may practice under supervision and be reimbursed by Medicaid, such as, for example, behavioral healthcare settings that have licensed clinical social workers as the supervising entities. And number 2, require that any person holding himself or herself out as a community health worker in the state be certified as a community health worker by the Nevada Certification Board. And committee members, Jay Colbert-Klausel is present to answer any questions that you may have. They also mentioned that the word certified should go in sub-item 2 before community health worker, so that it would read require that any person holding himself or herself out as a certified community health worker in the state be certified as a community health worker by the Nevada Certification Board. That was provided during public comment earlier today. Madam Chair.
Thank you, Mr. Ashton. Are there any questions regarding the recommendation with that requested revision to include certified before the first certified community health worker on item 2? Seeing none, I would entertain a motion. Sorry, go ahead. Yes,
I apologize. Little delay here. I just have some concerns. I certainly absolutely support community health workers. So I support the most of this proposal or this BDR, with the exception having them work under a licensed clinical social worker in a healthcare kind of setting, I have some concerns about that. And so I can't support this draft as presented. Thank you.
Thank you.
Madam
Any
Chair?
other question? Yes, please, Senator Hardy.
I'm intrigued. I think we need the concept of the community health workers. I think we need the certification of the community health workers. So my obvious question is, do we have a nationwide certification process that the community health worker passes a test, does so many hours, and thus gets a certificate that says, yes, I'm a certified community health worker that is viewed as such in other states and has the concept of that whole we're doing what other people do, so there's a consistency for what they do. And again, to Dr. Titus's point, when we talk about health or a community health worker, I think sometimes if we're listening to the words, we think they're going to be taking blood pressures or making sure the person takes their medicine or helping them with their rehabilitation. And now I'm going to have them under social workers. So is there a sub-certification of community health workers that works under social workers that are more prone to let's talk about it versus the community health worker that says this is the medicine you're supposed to be taking because, and this is your nutritional need, and this is the thing that you have to do to avoid getting sick, and you have to make sure that your blood pressure is taken. So I think the flexibility that we're talking about may be one of those questions that has to be worked out. I'm just kind of curious, what do we have subsets of community health workers? Because it would be unusual for a community health worker who's under a social worker to pretend that they're the community health worker who should be supervised under a doctor or a nurse practitioner or a PA. Question mark, question mark, question mark.
Thank you for the questions. And we do have Jay Colbert Classell. I'm so sorry if I said that inaccurately. Would you mind talking a little bit about the current certification process, how that was developed and what we're asking for here? And if there is a common certification process throughout the country? And can you also speak a little bit to what the scope of the workforce is for community health workers?
Jay Colbert Classell for the record. Chair Peters and committee members, there is not a national certification for community health workers. There is a national association, but the growth of the certification has been market-driven and also led by the states. So each state has developed their own certification process. The state of Nevada collaborated with the state of Washington and the state of Massachusetts primarily when developing their certification system through DPBH. And that was launched in November of 2018, I believe. The Nevada Certification Board reviews those applications for the DPBH approved curriculum that covers 13 competencies over an 8-week period. The next part of the question is on the scope of work. And I'd like to start by saying there is no such thing as a medical community health worker. That is out of the scope of what a community health worker is. A medical service should be provided by somebody who has the training and or licensing required for that. So taking a blood pressure, if the community health worker has the training to do that work, then they could do that. Assisting with medication, they can read the bottle to the client, help with translation, help give all those reminders so that the client can understand the method or the way that they're supposed to be taking their medication. But a community, to go onto that broader level, a community health worker should not be replacing what a social worker does. And so what they do is they help with a lot of those details, like making those calls to try to find housing, encouraging the client to just keep on that, spending that extra time with the client to help them achieve their case plan. But they don't write the case plan. One of the specific things that I like to tell social workers is a community health worker should not be asking things like the miracle question, like if you, because that's crossing over into therapy, where you're asking the client, if you could have, the world that you wanted. What would your perfect life look like? That's not the community health worker's role. A community health worker is there to help the client understand the options that are in front of them from a culturally competent standpoint. So our community health workers come from the communities that they're representing, but they're not bringing in medical training or behavioral health training. They're just helping spend that extra time with the client and extend the reach of those licensed and approved supervisors.
Madam Chair.
Thank you so much. Yes, please go ahead.
So how do you become certified in doing something that doesn't do health, doesn't do social work, and then is there an amorphous certification process that doesn't do social work and doesn't do health, but it's a community health worker?
So Jay Colbert-Classell for the record. We do have an extended program. So the College of Southern Nevada takes 13 weeks to go through the curriculum. They also add in some HIPAA training and mental health first aid. The Truckee Meadows Community College also has an approved training through DPBH that I don't remember their exact number of weeks, but it covers all the same competencies. Our curriculum is 8 weeks that we spend with the client, and we kind of teach them the roles and boundaries. So that's part of it, because a lot of community health workers are already out there, they're already doing a lot of work, but maybe they're not referring as much as they should be. And they need to have stronger connections with those licensed providers in both behavioral health and in physical health.
So if I may, Madam Chair, do you see the community health worker being an asset to a physician's office or a nurse practitioner's office, or are they working under somebody's direction, or are they autonomous in what they do, or could they be autonomous?
Jay Colbert-Classell for the record, through you, Chair. They should not be operating autonomously. In some of our rural areas, there are no other services. And so they end up in difficult positions where they just try to do the best for the client. And that's something that we'd like to remove and mitigate by encouraging them to form one of these contracts with a licensed provider and really fall under or go under the social services that we have in the state.
Madam Chair, I'm going to be supportive of this, recognizing that we have this huge need, but I think we need to put some boundaries on this in the legislative session that are inviting for people to become one, and then number two, how they're getting paid, and number three, what their results are. And do we have any way to be sure that the scope of practice is safe? But I will be supporting this, at least if you're ready for a motion, I think we should move with those caveats that I've got concerns.
Thank you so much. I had one more clarification from staff on the first point about the authority for Medicaid to kind of set supervisory roles. Mr. Ashton.
Thank you, Madam Chair. For the record, Patrick Ashton, this alludes to Dr. Titus's comment about licensed clinical social workers that may supervise community health workers. This year is really something that the committee may decide to strike from the language here from the work session document. The intent is to give Nevada Medicaid the flexibility to decide within their own policy authority who can be an appropriate supervising entity in any setting, medical setting, behavioral health care setting. And this is the flexibility and the intent of it, as I understood it from conversations with Nevada Medicaid. So the committee can decide to take out licensed clinical social workers here. That was merely in here as an example, and limited to say that Medicaid will have this flexibility. And I also want to state this is for Medicaid reimbursement. So because the issues, as alluded to in earlier presentations, were that right now it's limited to physicians, physician assistants, and advanced practice registered nurses who can be a supervising entity. This really would expand that and give the flexibility to Medicaid. Thank you, Madam Chair.
Thank you for that
Madam Chair?
clarification. Yes, please.
Madam Chair, so I mean, that's one of my concerns is Medicaid. It probably would require us to have a waiver to have Medicaid, apply for a waiver for Medicaid to cover a community health worker separate and distinct from somebody who already has the ability to be covered by Medicaid for what they do. Am I correct in that?
Jay
I believe we have.
Questel.
Sorry, Jay. I'm gonna.
I'll ask our staff.
And I'm gonna divert to Medicaid and see if Ms. Bierman can help us out here.
Thank you. Good afternoon, Chair Peters and the committee. So we added community health workers via state plan amendment. So my initial sense is that we would handle this via an amendment to the state plan, but certainly happy to follow up with our federal partners at CMS and verify that. So we can take that as a follow-up and report back to the committee, but my initial thinking is that it would likely be via state plan amendment.
I'm a little slow.
Thank you.
Chair, when you say a state plan amendment, are you saying that it would be an amendment to put them as an individual standalone person that gets eligibility to bill Medicaid, or be under somebody who does?
Suzanne Bierman for the record. I think we would be amending the types of providers that we would be reimbursing for these services. And those were added, the new provider type was added by a state plan amendment. So I think any expansion would also be handled via state plan amendment.
I'm a little slow again. Are you saying a standalone person as a community health worker, or are you calling a standalone not standalone, but be eligible to get paid for services under somebody who already has the ability to get Medicaid reimbursed?
I think it would, Suzanne Bierman for the record. I think it would be an expansion of how we define the provider type, which is outlined in our state plan amendment. So it would really be changing those requirements, which would, of course, require federal approval for this from the Centers for Medicare and Medicaid Services to further expand the types of providers that would be allowable for reimbursement as community health workers.
And so I would ask the obvious question, when you say for their services, what are their services that the people in the federal government would say, oh yeah, that's a Medicaid service that they need to do? Because I'm not sure what the nebulous description is that you're going to put in your application, but that's just me. Again, I think we need to move forward with it, but I think it has to have some fence around it. Thanks.
I appreciate your comments, and I think you're getting at some of what the work is to be done between now and session, and even within session on fleshing out the language to be included in the legislation. So, are there any other questions? Seeing none, I would entertain a motion. Vice Chair Doñate, and a second from Assemblywoman Gorlo. Is there any discussion on the motion? Seeing none, all those in favor, please signify by saying aye, raising your hand.
Aye.
Aye. Any opposed, please say nay.
Nay.
We have one nay from Dr. Titus. The motion passes. Thank you so much. That brings us to BDR recommendation item L.
For the record, Patrick Ashton, Committee Policy Analyst. Members, the following three recommendations under item L were developed by Vice Chair Donyate in consultation with committee staff in response to several roundtable discussions and stakeholder input during the COVID-19 health crisis interim study pursuant to SB 209 from the 2021 legislative session. After each recommendation, I will hand it back to the chair and the committee for further discussion and potential action. I will start with the recommendation on public health modernization, which you can find on page 10 of the work session document. The recommendation is to request a BDR to, number 1, authorize the establishment of health districts among non-adjacent counties in Nevada, specifically remove the word adjacent in subsection 1 of NRS 439-370, and make other conforming changes as needed. And number 2, establish an account for public health infrastructure and improvement in the State General Fund that is administered by DPPH. The fund shall appropriate general funds of $15 million each fiscal year for fiscal years 2023 to 2024 and 2024 to 2025. And then additionally, the following provisions apply as outlined on the work session document from A to F. Chair Peters and committee members, we have Julia Peak, DPPH Deputy Administrator, and Megan Komlossi, Associate Director of the Center for Public Health Excellence, UNR, present to respond to any questions you may have. Madam Chair.
Thank you, Mr. Ashton. Are there any questions from the committee? Seeing none, I would entertain a motion from Vice Chair Donyate and a second from Assemblywoman Gorlo. Any discussion on the motion before we vote? Seeing none, all those in favor, please signify by saying aye, raising your hand. Aye.
Aye.
Aye. Any opposed? Motion passes with those present. Thank you so much. We're going to go ahead and move on to the next recommendation under this item.
For the record, Patrick Ashton, Committee Policy Analyst. Next, we will continue with the recommendation on public health emergency preparedness under item L of the work session document, which you can find on page 11. This recommendation is to request a BDR to improve the public health emergency preparedness by providing in Chapter 414 of NRS that the use of the emergency assistance account is not dependent on the determination of an emergency by the governor. And item B, to require the Department of Employment, Training and Rehabilitation to conduct a study during the next legislative interim to explore alternative unemployment benefits, such as Kurzarbeit, and to evaluate essential versus non-essential businesses and workers in different types of crisis. There are much more items under this study requirement. All of it is outlined in the work session document. And committee members, we have also David Forgerson, Chief of the Division of Emergency Management and Homeland Security, and Alison Genko, Public Health Resources Officer in the Office of the Governor, present to answer questions. Madam Chair.
Thank you, Mr. Ashton. Are there any questions from the committee members on this item? Seeing none, I would entertain a motion from Vice Chair Donyate and a second from Assemblywoman Gorlo. Is there any discussion on the item before we vote? Seeing none, all those in favor, please signify by saying aye or raising your hand. Aye.
Aye.
Aye. Any opposed? Motion passes with those present. Thank you so much. Please proceed with the next recommendation.
For the record, Patrick Ashton, Committee Policy Analyst. Next, we have a BDR recommendation related to telehealth reimbursement parity. The work session document contains a summary on Senate Bill 5, which passed during the 2021 session on page 11 and 12. Among other provisions, SB 5 prohibited various third-party payers from refusing to pay for services provided through telehealth because of the technology used, and categorizing telehealth services differently than services provided in person for purposes related to coverage or reimbursement. In addition, SB 5 required third-party payers to cover telehealth services in the same amount as services provided in person or by other means, except for services provided through audio-only interaction. These reimbursement parity requirements for telehealth services were temporary, facilitating access to telehealth only for the duration of the COVID-19 public health emergency. The recommendation is to request a BDR to repeal the sunset requirements for all reimbursement parity requirements for telehealth services pursuant to SB 5, and thereby making all reimbursement parity requirements permanent. Madam Chair.
Thank you. Are there any questions on this item?
Madam Chair.
Assemblywoman Titus.
Thank
yes,
you.
Please go ahead.
I certainly appreciate telehealth and especially in rural areas. And if anything, COVID brought out that the access to healthcare can be tough. But I'm concerned about the parity of reimbursement now with those who might have brick and mortar buildings in the state. And I'm going to not support this because I'm anxious about how it's going to turn out as it finalizes, and again, making certain other requirements for telehealth. And so I won't be able to support this at this time. Thank you.
Thank you. Vice Chair Doniate.
Thank you so much, Chair Peters. I just want to share one sentiment, which is I think that the field of telemedicine or telehealth in the umbrella is still very new. And there is research that's coming out determining the efficacy of one mode versus the other. My understanding is that CMS right now is collecting feedback from providers nationwide to see if audio services can relate to an in-person visit and what the nuances are covering that. But a lot of that we'll learn as we continue moving forward throughout the COVID-19 pandemic as it turns to an endemic, and of course with other public health crises that come about. So my hope is that when this bill does come out during the legislature, that we can have those conversations and debates as to what requirements do come forward during a public health emergency similar to COVID-19, or if we want to make them permanent to entice digital health companies to come to the state, or what that looks like. So I think that's the intent of this proposal.
Thank you so much. And I want to take a moment to just discuss that during the legislative session, when we decided to put these sunsets on in committee, we did make a commitment to come back around to assess the requirements for parity with telemedicine. And so I feel like this is a good starting point with that. But again, the bill ends up going through a process, and we are just at the beginning of that. So any other comments or questions from the committee? Seeing none, I would entertain a motion from Vice Chair Doniate and a second from Assemblywoman Gorlo. Thank you so much. Any discussion on the motion before we vote? Seeing none, all those in favor signify by saying aye or raising your hand. Aye. Aye. Any opposed?
Nay.
A nay from Assemblywoman Titus. The motion passes. We're going to go ahead and move on to BDR recommendation item M. I didn't skip one, right? M.
For the record, Patrick Ashton, Committee Policy Analyst. These are now recommendations to draft letters. We are under item M. This is a recommendation was developed by Chair Peters in response to a recommendation provided by Marlene Lockhart from the Service Employees International Union Local 1107 during the solicitation of recommendations period. The recommendation is to draft letters to the Senate and Assembly Health and Human Services Committees and the Director of DHHS, expressing the committee's support for the recommendations identified by the Home Care Employment Standards Board created by SB 340 last session. And committee members, we have Cody Finney present from DHHS, and she's also the chair of the Home Care Employment Standards Board. She could respond to any questions you may have. Madam Chair.
Thank you, Mr. Ashton. I did misspeak. We are on draft letters. These are not BDRs. These are just letters from the committee that suggest our support as described in the items. Are there any questions on this item? Seeing none, I would go ahead and accept a motion from Vice Chair Doniate and a second from Assemblywoman Gorlo. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye or raising your hand. Aye. Any opposed? Nay. Motion passes with those present. Thank you so much. Please proceed with letter item N.
Thank you, Madam Chair. Item N you can find on page 12 of the work session document, and this recommendation was developed by Chair Peters in consultation with committee staff and in response to multiple testimony provided at the May 19th HHS meeting. The recommendation is to draft letters to the Senate Committee on Finance and Assembly Ways and Means and the Director of DHHS expressing the committee's support for budget items considered for special considerations regarding providing adult dental coverage at federally qualified health centers and extending Medicaid postpartum coverage to 12 months. We have several stakeholders and subject matter experts present to answer any questions the committee may have. Madam Chair.
Thank you so much. Are there any questions from the committee? Seeing none, I would entertain a motion. Senator Doniate, second from Assemblywoman Gorlo. Is there any discussion on the item? Seeing none, all those in favor, please signify by saying aye, raising your hand. Aye. Any opposed? Nay. No. The motion passes with those present. Thank you all so much. I believe that brings us to the end of our work session agenda item. Please correct me if I'm wrong. Good. Okay. We're going to close that item. Thank you all so much for your input and questions. Always appreciate the discussion and look forward to future discussions as we move through the legislative session. I'm going to open agenda item.
Madam Chair, before we go to public comment?
Yes, please go ahead.
Madam Chair, I just want to acknowledge the committee's hard efforts and work and all the hearings and folks that have contributed to improve the health of all Nevadans throughout our state. So this is our last meeting in this committee, and the time that has been spent has been impressive. And I think we've gotten some good things moving forward, looking forward to further conversations. And thank you to all committee members and workers, and especially you, Madam Chair, for taking on these tasks.
Thank you so much for that. Go ahead, Senator Hardy.
Thank you. Appreciate what you've done, and our staff, and I'll call him Eric. There I go. Mr. Robbins and Patrick, who have been personally helpful to me and in my position. And I appreciate the opportunity to have served on this committee and these long years. And I look forward to continuing good relationships with all of you. But I'll give you the ball and let you continue to carry it. Thank you very much.
Thank you for sharing the sentiments. I was going to wait until after public comment to share, but similarly, I have very much appreciated working in service with all of you over this interim. I've appreciated all of the effort put in by the entities who have come before us and those who have shared their opinions, their expertise, and their life stories on these really important issues. But I also want to take a moment to extend our appreciation to you, Senator Hardy. It's been a really a pleasure serving with you in this capacity. I don't think we've served on a committee together before, and this being your last committee, it really feels like I missed out on a little bit not having served with you previously to this. We want to wish you best luck in your next chapter. You will be missed. Thank you so much for all of your service and the concern for your community and your willingness to always come to the table and have discussions on these really important issues to our community. So thank you for your service, Senator Hardy. We are looking forward to seeing how things go in the next chapter of your life. I also want to extend an enormous thank you to our staff, who are not quite done yet. I think their work is just getting started, actually. We could not have done this committee without you. I would have been a hot mess and have oftentimes, I think, shown up in ways as a hot mess. You guys have helped keep us reined in and coordinating with our stakeholders and with our agencies, making sure that I have notes drafted in ways that are helpful to getting us through committees. You are invaluable. Thank you so much for your help and for the work that you do. And I'm going to move us into public comment with that. And this is our last public comment of the interim. We have physical locations and online. I'm going to go ahead and ask folks to please continue to limit your comments to 3 minutes. Is there anybody in Las Vegas who'd like to come up for public comment at this time? Not seeing anyone in Las Vegas approaching for public comment. In Carson City, is there anybody who would like to approach for public comment? I can just barely see a reflection. I don't see anybody coming up. So I'm going to go ahead and move on to BPS. Is there anybody on the public comment line for public comment today?
No, Chair. The public line is open and working, but there are no callers at this time.
Fantastic. Well, thank you again. This is our final meeting. We will be working on these BDRs, and I look forward to Senator Doñate. Do you have a? Okay, please, Vice Chair Doñate.
Thank you so much, Chair Peters. Before we conclude, I just want to express my gratitude to you, of course, for bringing me alongside the decision-making process, and of course, to the unsung heroes of some of the bills today, which were the biggest task. I think the COVID-19 bills, our committee staff guided us throughout that process. I know that we didn't get a lot of it into those bills, but hopefully we're just getting started on some of those processes. And of course, to Doc Hardy, I think a lot of us share the same sentiment. You've been very gracious to work with, sir, and it was such an honor to have the ability to work with you in the Senate. I'm truly going to miss you, and I hope that in this respect, I think the city of the folks of Boulder City are lucky to have your service, sir. So thank you so much for serving and for your expertise, and I look forward to hopefully still pulling you into this committee meeting at some point in the future for your expertise. So thank you so much, sir.
Thank you. I was remiss on all of your effort, also acknowledging all your effort on that COVID-19 study, really bringing some amazing stakeholder groups together and talking about these dynamic issues, and also for serving with me and helping make these hard decisions. Like, I don't know how folks do this by themselves. It's really a group effort. And we had an amazing one, you guys. I'm really, really proud of the work we've done in this committee. With that, the meeting is adjourned.